So, sir, 3, 2, 1. Over to you, sir.
Can start recording. Yes, sir. Ashok, sir.
Good morning. Today, on the second Sunday of the month of May of 2025, FOGSI ICOG has come with PG clinic, and this is 11:30 a.m., second Sunday of the month. And we have Dr. Parag Biniwala with us, chairperson of ICOG. And at the outset, I, along with my team, Dr. Ashish Mukhopadhyay, Dr. Hafizur Rahman, would like to express sincere gratitude to FOGSI President Dr. Sunita Tendulwarkar, Dr. Parag Biniwala, chairperson ICOG, Vice Chair-elect Dr. Sheila Mane, Dr. Suvarna Khadilkar, Secretary General FOGSI, Dr. Sarita Bhalerao, Secretary ICOG, and other office bearers of FOGSI and ICOG for supporting us in this endeavor of FOGSI ICOG PG clinic every month. As you know, this program is going on for more than 3 years, and we are having this program for the benefit of many teachers and many students all over the country. We always try to include the teachers from different parts of the country and students also from different parts of the country. And it is our always endeavor to rope in different medical colleges and students from the remote areas of the country so that they can also participate and learn and take benefit and advantages from the program. So with these words, I just also want to inform everyone that the recording of these programs and all previous programs are also available on the ICOG website. And so before starting, I would like to welcome our chairperson, Dr. Parag Biniwala, and I invite him to say a few words.
Thank you, Dr. Ashok. Good morning. I bring greetings from ICOG, and it's indeed a pleasure to welcome everyone on yet another episode of PG Clinics. I must appreciate efforts put in by Dr. Ashok Kumar, Dr. Ashish Mukhopadhyay, and Dr. Hafizur Rahman, who persistently for last 3 years plus spent their second Sundays educating students and dedicating time to ICOG. Thank you guys for all your help all these years. I must thank our teachers today, Professor Arup Kumar Maji. Thank you, Arupda. Team of AIMS Raebareli who are going to have case presentation, and of course our examiners today, which include Dr. Nirmala C, Dr. Manideep Pal, and Dr. Deepa Lokwani. Of course, thank you to Dr. Meena Samant, who's going to speak on Master the Technique today, and she's going to demonstrate the abdominal examination. The aim of this program basically is to educate students and prepare them better for the examination. And this is our small bit from ICOG we are doing for last 3 years. And I also take this opportunity to invite all the teachers for the new program that we've started, Odyssey of Teachers, which is coordinated by Dr. Ashok Kumar and Dr. Vidya Thubi. Welcome, Vidya, for this episode today. And we would like to have participation from more and more teachers, because this is again a small attempt to reach out to professors from smaller places where the newer teaching modalities of NMC are not well versed with. So my best wishes for the program, and see you again on the next episode of Odyssey with Teachers, which we will be announcing very, very soon. Thank you.
Thank you, Dr. Parag Biniwala. Before we start the program, actually, I would just like to introduce this program for the participants who have joined recently. We have three components in this. One is Master the Dummy Pelvis, where the demonstration is on pelvis and dummy, and the baby fetus also, or the newborn. And we try to learn the fetal skull and maternal pelvis in detail. Then we have case discussion where we discuss one case like we have in the exam, and the student present the case and the examiner will discuss and evaluate the students. After that, we try to do the skill-based learning and we try to develop the skill for the students. And we have this section on master the technique. We try to demonstrate various easy procedures for the students so that they can learn and they can develop the skill of doing that technique or that part of the component which we have to learn compulsory. And recently we have added quiz component also in this, and last half an hour of the program is for the quiz where students take part with keen interest and try to solve the puzzles. So these are the things which we are doing, and we try to always follow the NMC guideline where now the emphasis is on competency-based learning and skill development. So we try to uh, include these type of exercises in our program. So once again, we welcome all our faculty and the students uh, for sparing their valuable time for this program. I welcome you all to this program, and I hope today's deliberation will give a thorough insight into the topics which we are going to discuss. So I now invite Dr. Ashish Mukhopadhyay sir to say a few words, and then then Dr. Hafizur Rahman will continue with the proceedings of the program. Thank you.
Thank you, Dr. Ashok Kumar. And it is my pleasure and privilege to welcome all of you in this common forum called PG Clinic, which we organize every second Sunday of every month. And this has been going on for last 3 months. And I think that this curriculum of this program or the contents of this program are evolving continuously. And thank you, Dr. Parag Biniwale, for including the fourth component, that is the quiz program. Erstwhile, we had 3 components as detailed by Dr. Ashok Kumar as per NMC guidelines. This is a perfect combination of NMC guidelines as well as the learning, which happens according to ICOG's own commitment. I believe this is extremely useful because I keep on getting feedback from the students all over the country about the usefulness of the case presentation, master the technique, etc., etc. And we would like to continue, and also not only in the content, but also we have included many participant colleges like AIMS Library is a new addition here. In the last 3 weeks also, 3 months also, we added some new venues here, and we wish to continue in this. We would like to add new venues, and we will prepare a list of the colleges who want to participate, because we know that many medical colleges are coming up with a lot of developments in OBGYN, and they are showing keen interest in participating in this program. So we'll make a list of them, we'll prioritize them, and ultimately we will circulate this amongst you. And we will also ensure that, as our chairman said, the medical colleges who have not done once also here will get the priority. So with that motto in mind and wishing to continue to serve the students and the teachers together, I would like to invite all of you with folded hands, and let us come and enjoy and share and participate the knowledge. Thank you very much. And Hafizur, please start the program.
Yeah, thank you, sir. It's got a very good morning to everyone. Thank you, Parag sir, chairperson, and Ashok sir for having this program continuously we are doing. And what we can see, as we have seen, we are getting actually, previously we used to get the colleges. Now we are getting requests from the colleges, that is their PG students are interested. So we'll be doing the things. So now for today's session, that is, we are going to have in the very first session, as we are doing, the first session is master the dummy pelvis. So we'll start from where we are in the last session. That means what is not covered because in the last session, it was covered on the basics of dummy pelvis. So that today, Dr. Arop Kumar Maji sir will present on various diameters, landmarks, and joints for maternal pelvis and fetal-pelvic relationship with their clinical significance. So it is more of a like applied importance, as well as sir will be demonstrating some of the different aspects for the postgraduate presentation. So sir is Arup Kumar Majhi sir is professor at Santiniketan Medical College. It is Bolpur in West Bengal. Then followed by we'll have the case presentation. The case presentation, as it is mentioned, it will be done by AIMS Raebareli students on a pelvic organ prolapse. And the case will be presented by Dr. Aditi Keshwar Chaurera and Dr. J.R. Rahman. And we have the faculties, Dr. Ashish Mukhopadhyay sir, then Dr. Nirmala C. Madam was Professor Sri Mukambika Institute of Medical Sciences, that's Kanyakumari. Then we have another expert in this area, Dr. Manidip Paul, sir is Principal and Professor, College of Medicine and JNM Hospital, Kallani. And Dr. Deepa Lapani, Madam is Professor at Jaipur National University Institute of Medical Sciences and Research Center. Then we have, as it is mentioned, for a technical session and followed by quiz. So I'll not have much time on this. I'll go straightly to request Professor Arup Kumar Majhi sir to start sir on demonstration on various diameters, landmarks, and joints of maternal pelvis and fetal-pelvic relationship and their clinical significance. For demonstrations to Arup Kumar Majhi sir. Over to you, sir, for your demonstration. Thank you, sir.
Thank you. Good morning, everybody. Dr. Parag, Dr. Ashok Kumar, Dr. Ashish, and Dr. Hafizur for giving me this scope, the mastering the dummy pelvis. Today, I want to demonstrate some of the things, mainly on the concentrate. Is it visible and audible?
Yes, sir. Better.
Can you make it full screen, please? Technical. Yes, that looks better.
So now I am going to discuss very two important aspects. One is the pelvic joints, role of the pelvic joints in the normal labor and abnormal labor, and also what are the changing of the diameter causing the different abnormal pelvis, and how the mechanism occurs in case of abnormal pelvis, the pelvis adopts. Now, first, what are the in pelvis? We know their pelvis is component of the three bones. One is the two innominate bones, and one sacrum, and another is the coccyx and the symphysis joint. So now come to the point. Is the what are the different joints? Different joints mean important. Most important joint is the sacroiliac joint, and another is the symphysis pubis, and another sacrococcygeal joint. Sacrococcygeal joint. You can see the sacrococcygeal joint. Now, regarding the joints, I can say that it is the points are not really addressed properly. The joints are grown during the pregnancy and also in the labor. Joints become all the joints during the pregnancy, particularly in case of term pregnancy and during the labor, there are the softening of the joint, the relaxation of the joints, and some form of mobility occurs. So I will discuss the one by one how the joints has role in the normal labor in labor. You can see the first joint. You can see this is actually the sacrococcygeal joints. This sacrococcygeal joint. This is normally what happens, the anteroposterior diameter of the outlet, if you see, the lower order of the symphysis pubis up to the tip of the coccyx, this is 10.5 centimeter. But what happens in the late second stage, the coccyx is deviated to the posteriorly. So ultimately, the diameter is 13 centimeter. So coccyx is not obstruction anyway. That is why in practical sense, the outlet diameter is seems the lower one of the symphysis pubis to the tip of the coccyx, tip of the sacrum, which is 11.5 centimeter. So if there is as there is mobility, so no problem in the delivery in coccyx. But some pathological conditions may occur, like if the sacrococcygeal joints there is a fibrosis and cannot move properly, what will happen? The coccyx may sometimes obstruct. And there is a fuse hook appearance. That is, the coccyx is bent. Coccyx is bent anteriorly, and there is a fuse hook. There is a fuse hook appearance. Fuse hook appearance, with the fish hook appearance of the coccyx, fish hook appearance. And what happened when the head is delivered at the outlet, so it will press over the fish hook of coccyx. And when the forceps, particularly the forceps of giving, in these cases, what will happen? There will be the fracture of the coccyx. So what is done in that case, that in case of outlet, it will be wise to make the fetal head to some extent oblique, so that the coccyx does not press over the head, does not press over the coccyx. So this is the one of the clinical importance of, just though rare, but it may happen about the pathology of the coccyx. Now put the symphysis pubis joint. All of you know the symphysis pubis joint is the fibrocartilaginous joint, and there is some laxity of the joint, and above there is a superior ligament and there is the inferior ligament, and this is called the arcuate ligament of the pelvis. And there is some softening and laxity of the joints during the pregnancy and also during the labor. And during labor, particularly in case of multigravida, the symphysis pubis may wide shoot to some extent, may be wide to some extent. And next, the significance of this joint is another significance of this joint is that if you other than the natural wideness, if you want to do the enlarge the outlet, you can do the symphysotomy. The role of symphysotomy is still there, is particularly in the developed candy in obstructed labor, where there is a moderate degree of the pelvic deformation and some cases of the shoulder dystocia, and rarely it is also the breech delivery after coming out of the bed delivery. It is actually the ligament, which is the superior ligament and the inferior ligament, that will actually prevent for the wideness of the symphysis pubis. So it is a 5 minutes procedure, though as an expert must can do, but preventing the rupture of the damage of the urethra. That is very important, damage of the urethra, but takes only the 5 minutes, and cutting of the ligaments and the symphysis pubis, that will enlarge about 2 to 2.5 centimeter the outlet of the pelvis. Now come to the sacroiliac joint. In fact, the sacroiliac joint is the most important joint. It is the softness, and also there is upward gliding. That is the upward gliding movement of the sacroiliac joint. Not only in the labor, it also helps in the term pregnancy. Upward gliding movement. This is the sacroiliac joint. Upward gliding movement helps the widening of the outlet. How does it cause? I am going to that upward gliding, and it increases the outlet. It increases the outlet about 1.5 to 2 centimeter. This is upward gliding, provided the sacrum also rotates posteriorly. So it rotates posteriorly, and upward gliding of the joint, that also increases the outlet. And this maximum movement occurs in case of dorsal lithotomy position. So some dorsal lithotomy position, if you deliver or even in the dorsal position, what happens? The outlet increases about the 2 centimeter, outlet about the 2 centimeter. That is the upward gliding of the sacroiliac joint, which here becomes suffer during pregnancy and also during the labor. This is one thing. So that is the one choice of the delivery, that the dorsal position, and also the dorsal lithotomy position. And how does some in the primitive areas, primitive societies, they use the squatting position, modified squatting position. That is like this delivery squatting. This squatting position also helps for increase of the bispinous diameter, and also increase of the outlet about 2 centimeter. This is also due to the change of the main role is the sacroiliac joint, that is the upward gliding of the sacroiliac joint. So this posture, that is the squatting position, is preferable by some primitive areas. Still there. There are many positions which is described in the guideline books. There is a position of the delivery. This is one of the preferred and advantage, the increase of the bispinous diameter and increase of the outlet. Now come to the the clinical application of the sacroiliac joint and what happens, you will see what happens. You will see in case of what you will see in case of Magrovard's maneuver. In the Magrovard, what is the Macrovard maneuver in case of shoulder dystocia. In case of shoulder dystocia, you can see in case of shoulder dystocia. In shoulder dystocia, you know the shoulder dystocia. What happened? Actually the bispinous diameter is bispinous comes in the anteroposterior diameter of the pelvic inlet and anteroposterior diameter of the pelvic inlet. So in the shoulder dystocia, anteroposterior diameter of the pelvic inlet, and anterior shoulder comes above the symphysis pubis, and it is wedged in the posterior to the symphysis pubis. And normally, in case of unilateral, the posterior shoulder comes below the sacral with the pelvic inlet. But sometimes, very rarely, both the shoulders shoulder impaction occurs. And all of you know the shoulder dystocia is a very dangerous thing, deadly, and needs immediate attention. Immediate attention in immediate emergency, that is the shoulder dystocia skill. Otherwise, the baby may be expected even the die, even maybe die due to the cord compression. Actually, mainly due to the cord compression. Mainly due to the cord compression. So that is there are so many methods for the disinfection, but one of the important methods and first, it is the Magrovard maneuver. What is done is actually the Magrovard maneuver. What is done is actually in the Magrovard maneuver. You can see in Magrovard maneuver, what is done is actually, you see the Magrovard maneuver. You see in the Magrovard maneuver, what is done? You see what is done is actually give the picture here. The very good picture. You see Magrovard maneuver. What is done is actually, you see in case of Magrovard maneuver, what is done? That is the mother's leg. You see here the mother's leg is knee flexion in the knee joint. There is a flexion in the knee joint normally. If it is a stirrup, you open from the stirrup, and what is done? Suddenly flexion of the hip joint suddenly with slight abduction. So three movements occur in the three important points here in Magrovard's maneuver. That is the flexion of the knee joint and the sudden flexion of the knee joint with slight abduction. It will cause what will it cause? It will make the sacrum. It is the make the sacrum states with the lumbar vertebra, lumbar spines. Sacrum states with the lumbar spine, and the angle of inclination is decreased. Angle of inclination with the angle between the sacrum, and the lumbar, that is increased. And main thing is that the symphysis pubis, which is the symphysis pubis, that is the symphysis pubis rotates cephaloid. Rotates cephaloid. It is a rotates cephaloid, and that releases the fetal head impacted the shoulder. So this is the basic thing occurs. One is the straightening of the sacrum with the lumbar spine, and second thing is the inclination of the pelvis with the lumbar spine because decreased, and the main thing is that symphysis pubis is elevated, goes cephaloid to the mother's abdomen, and that will release the symphysis that is with the anterior shoulder. And this is aided by actually the sacroiliac joint as the upward gliding of the sacroiliac joint. And another associated things are done here in the Magrovard's maneuver. What is done? If you can see the picture, the head, the suprapubic pressure. Suprapubic pressure is given or the acromion process. Suprapubic pressure is given in the pressure on the anterior shoulder, and this pressure is given. Downwards and laterally. So what happens there? For downwards and laterally, normally the bisacral diameter, which is 12 centimeter, lies anteroposteriorly. This will go to the oblique diameter of the pelvis. that is the oblique diameter is a large diameter in case of pelvis. And also as the downward traction, there is downward traction, this also helps to release the downwards and pressure over there, suprapubic pressure. The bisacrum diameter is to some extent lessened and the delivery occur. And during this time, what is to be done? That is the delivery of the head can be done. Before that, what is to do? Delivery of the head is done very gently and with the uterine contraction at the time of the uterine contraction. At the time of the uterine contraction and with the bearing development, gentle traction is done, and the delivery of the shoulder is attempted, and usually it becomes successful. Don't give the fundal pressure. That will the anterior shoulder will be more impaction will be done, and don't give the much of traction that will cause the permanent damage of the brachial plexus. So I have described the macropod maneuvers. What is macropod maneuver and the shoulder dystocia, and what is the additional procedure is done by suprapubic pressures, medially suprapubic pressure downwards and the laterally, that will release the impacted, impacted shoulder. Usually this procedure becomes successful, but which method is ideal? It is very difficult to say. There is a controversial, but this is the first procedure. There are so many other methods of that is the Rubin's method, Woodcock's method, and so many posterior approach. There are so many methods. I am not going into detail of the, but this I am describing here. This is done by help from the aiding from the movement of the sacroiliac joint and just changing the direction of the pelvis. Now the second part will come to the abnormality of the pelvis, abnormal pelvis. We know that in case of abnormal pelvis, basically there are the four pelvis. The female pelvis. One is the gynecoid pelvis, another is the android pelvis, another is the anthropoid pelvis, and another is the platypoid pelvis. The platypoid pelvis. So if hot gynecoid pelvis occurs, gynecoid is almost the round pelvis, only the posteriorly depressed due to the presence of the segmental. In when the good gynecoid pelvis, no problem of the delivery with normal mechanism. I am now going into detail. It has been discussed before. But what happens in the other pelvis? Actually, if you go to the different types of pelvis, 4 types of pelvis, the pelvis are divided. The pelvis are mainly the cardioid and malloy, and divided the type of pelvis on the basis of the pelvic, that is the inlet, the configuration of the inlet, shape of the inlet. And this is the inlet is subdivided by the maximum transverse diameter, subdivided by the maximum transverse diameter. That is the maximum transverse diameter. This is the maximum transverse diameter, which divides the posterior segment and the anterior segment. That is furthest apart points in the this line. That is the furthest apart point, that is the maximum transverse diameter. And so that divides in the anterior segment and the posterior segment. And what happens in the division, the posterior segment is actually the type of the pelvis, and anterior segment the tendency. Suppose the gyne-android pelvis, that means the posterior segment is like the gynecoid pelvis, and android means the anterior part is like the tendency of the android. So pelvis may be the mixed type, and majority of the pelvis, female pelvis, is usually 50% the gynecoid pelvis, and 22.5% is the android pelvis. 22.5% average is the malloy and condylar classification was that, and incidence was also. That is the 22.5% is the android pelvis, and only 2 to 5% in case of platypoid pelvis. Now, Now, one by one, I am coming the different pelvis and the mechanism how it occurs. Now you see, if the maximum transverse, there is a maximum transverse with the iliopectineal line maximum transverse diameter in case of android pelvis if you see the android pelvis, what happens is actually android pelvis. It is actually the triangular pelvis or the wedge-shaped pelvis, like the triangular leg. So the posterior sagittal diameter, posterior part of the conjugate, total conjugate, is the very smaller. That is a very smaller portion. And anterior portion also there is maybe the small in case of triangular pelvis. But main part is the posteriorly there is no space in the inlay. What happens in the other part, other landmarks of the pelvic inlay? What is that is the, if you see, that is the retropelvic space. Retropelvic space, you can see the gynecoid pelvis is almost near 180 degree and flat pelvis and gynecoid pelvis. But here, in case of android pelvis, it is beaked shaped. That is retropelvic angle is as acute. So there is a anterior space is less. Anterior space is also narrow. Anteriorly, it is also the narrow. Now, what is the mid pelvis? If you go the sacral angles mean the angle between the pelvic inlet and the sacrum, anterior surface of the sacrum. This is less than 90 degree. Normally, it is less than 90, more than 90 to 100 degree, and sacral curvature is when curved, normal, in normal pelvis. But here occurred the less than 90 degree, and also is the flat pelvis, is the flat. So, and with the sacrum becomes a flat. And what about the lateral wall, lateral engine in the, instead of divergent or the parallel, it becomes the convergent. And bispinous diameter is also less. And posterior sagittal diameter also loss of the mid pelvic plane. So what happens is actually the funnel shaped pelvis. This is also the funnel pelvis. That is the posteriorly there is the projected, there is the pelvis, the sacrum is goes anteriorly, and laterally there is also the convergence. So there is a funnel shaped pelvis. So there is a mid pelvic contraction. What is about the outlet? In outlet, you can see the subpelvic, the pelvic arch. Pelvic arch is the pelvic arch is the narrow pelvic arch, and the subpelvic angle in case of android pelvis, it near about the 60 degree, which is more in case of 80 degree, 90 degree or like that. So, and this subpelvic arch cannot take the two fingers also here. So the available transverse diameter is less. Why? There is a waist space of Morris, that is the distance from the lower border of the symphysis pelvis, the circumference of the fetal head. It is more than 1 centimeter. So available transverse diameter, the outlet is also less. What is the mechanism? How is the mechanism occurs in case of the android pelvis? You see the mechanism in the case of android pelvis is majority of the cases is there is a delayed engagement, or even if the gross cephalopoid portion no engagement. If engagement occurs, the delayed engagement, so what happens here? Engagement is the one of the oblique diameter or transverse diameter, one of the oblique diameter or transverse diameter. And in fact, as the mid pelvis there is a contraction, no space, though no rotation occur. So obstetric aid is needed. If you think assess the pelvis again, cephalopelvis relation you see. If not safe, do the cesarean section. Otherwise, you can do what you can do. That is the manual rotation and the forceps extraction, or the ventus, or you can do the ventus extraction. That is also difficult. Suppose you have done the manual rotation and forceps extraction. What will happen if the outlet space is also less? So what will happen as the outlet space is the head more goes toward the perineum? So what will happen? There is a chance of complete perineal tear, higher degree of the oasis there. And so maybe majority of cases may be asphyxiated. In this case, it is not properly handle the obstetrics. So this is the android pelvis mechanism. Android mechanism, it enters difficulty in the inlet, and also difficulty in the mid pelvic, and also the outlet. The most type of pelvis in the android pelvis. Now come to the anthropoid pelvis. What happens in the anthropoid pelvis? Anthropoid pelvis, the anteroposterior diameter is larger than the transverse diameter. anteroposterior diameter is larger than the transverse diameter. So there is a more room in the posteriorly, but the anteriorly there is a this is the fore pelvis is narrow. Fore pelvis is narrow. Though anteroposterior diameter is much, the fore pelvis is narrow, and these the retropubic angle. That retropubic angle. So the retropubic angle. This is not like the along the gynecoid pelvis or the flat pelvis. To some extent, it is also narrow. And the subpubic and what is the mid pelvis? What is the mid pelvis? Usually, in case of anthropoid pelvis, the mid pelvic is parallel to each other. But to some extent, the bispinous diameter, their prominent bispinous diameter, the normal bispinous diameter is 10.5 centimeter. That is at the plane of the inlay. But here, maybe little more less than the 10.5 centimeter. But the anteroposterior diameter is the no problem, because no problem. Anteroposterior diameter in the all the plane and also in the outlet, that is the from the lower part of the symphysis pubis on the tip of the sacrum, there is no problem. So what will happen? What is the mechanism of the anthropoid? With this background of the description of the anthropoid pelvis, you can say anthropoid pelvis, as there is a large space on the posteriorly, So what will happen? Usually there is a engagement occurs. The sagittal suture keeping anteriorly in the one of the conjugate along the conjugate, that is the obstetric conjugate or true conjugate, whatever you say. These are different in the anteroposterior. So sagittal suture. Is the anteroposteriorly like anteroposteriorly. So it is engages in the direct occiputo-posterior, or even it may go to the direct occiputo-anterior. If there is a direct occiputo-anterior and occiputo, so delivery usually not they are not interfered. Delivery occurs as the normal mechanism of the liver. But if the occiputo-posterior, the long rotation, if there is a long rotation, which is not so possible, long rotation for the normal delivery. So what happens? That is the phase 2 pelvis delivery. The phase 2 pelvis delivery. What occurs in the phase 2 pelvis delivery? The symphysis in the phase 2 pelvis delivery, what happens? The root of the nose, that is the root of the nose, hinges under the symphysis pubis, that is the symphysis pubis, and symphysis pubis, and first the brow, and the that is the first the brow, and that is the vertex is delivered. Vertex is delivered. The vertex is delivered by flexion, and the face is delivered by the extension. So this is the mechanism of the phase 2 pelvis delivery. Commonly occurs in case of anthropoid, in case of anthropoid pelvis. Now, here the chance of the perineal tear is less in comparison to the anteroid pelvis, and is the long anteroposterior diameter. So this is about the anthropoid pelvis. Now very interesting is the platypoid pelvis. The platypoid pelvis, the incidence is 2.5 to 5%. Platypoid pelvis, what happens? That is the transverse diameter is more than the anteroposterior diameter. Transverse diameter is more than the anteroposterior diameter. So here what happens, and the mid pelvis, in case of mid pelvis, the mid pelvis is the divergent. Mid pelvis, the lateral walls are divergent, and bispinous diameter is large, and there is no problem in the outlet. So in case of platyploid pelvis, only problem is in the engagement. So how does engagement occur? As the platyploid, the flat pelvis, engagement offers one of the transverse diameter. That is the sagittal diameter transversely. First attempt is what happens? The biparietal diameter, that is the biparietal diameter, tries to engage. That is the biparietal diameter. You see, this is the biparietal diameter. But as the biparietal diameter 9.5 centimeter, so asynclitism occurs. This is the superose of parietal diameter. One is the supero subparietal diameter, which is 8.5 centimeter. So first, there is a there may be chance that is the biparietal diameter engaged. As the anteroposterior diameter is less, so biparietal diameter is instead of biparietal diameter, the supero-subparietal diameter is engages, which is 8.5 centimeter. That is the asyncretism occur. In case of anterior, if the anterior bone present, that is called the anterior asyncretism. If the posterior bone present, it is called the posterior. Suppose still the biparietal diameter, the anteroposterior diameter cannot accommodate the supero-subparietal diameter. What happened? The interesting thing is that it will glide laterally. It will displacement of the occiput laterally. In which parts there is the occiput displaced laterally, and what happens? This is only there is no completion of the flexion occur. So in comes deflex condition. Here the biparietal diameter engages in the sacrocotyloid diameter. Sacrocotyloid diameter. This is the importance of the sacrocotyloid diameter. This is not the oblique diameter, the right and left oblique diameter. It's from the sacral promontory to the ilioepiphyseal. Yeah. So the postgraduate here clearly the sacrocotyloid diameter of the sacral promontory to iliopubic eminence. And oblique diameter is the sacroiliac joint to the iliopubic. So it engages in the sacrocotyloid diameter. And then flexions occur as there is a much space, occiput descends and the internal rotations occur, delivery occurs by the normal delivery. So the extension and then the restitution and external rotation. So that is the basis of the flat pelvis. But in some rare cases, what happens? Suppose there is no lateral displacement. In case of lateral displacement, what happens? The biparietal diameter engages in the sacrocotyloid diameter, and biparietal diameter engages in the anteroposterior conjugate, anteroposterior diameter. Suppose there is no lateral displacement. What will happen? There will be extension of the head, So mentum goes downwards, and so that will the either face presentation or the rarely the brow presentation. If there is a face presentation, the face mentor anterior, what happens? And what happens in the mentor anterior? Thus, the submentum hinges under the symphysis pubis already extended, and his head delivered by the flexion, the face and the brow and the vertex. So, in summary of the platypoid pelvis, what happens? In summary of the platypoid pelvis, head tries to engage in the biparietal diameter with the sagittal to transversely, and it may not be possible. So, supero subparietal diameter engages in the anteroposterior diameter by asyncretism. If it is also not possible, so there is a lateral displacement commonly occurs in the flat pelvis, commonly occur. So, it engages in the sacrocotyloid diameter, which is 9.5 centimeter. It is also 9.5 centimeter. Sacrocotyloid length is the 9.5 centimeter. All sacral promontory of the and as there is a space, there is a flexion of the occiput, flexion of the head. So occiput descends and head is delivered normally. In very rare cases, if the extensions occur, the head, either face presentation or brow presentation. If the mentro and posterior face and brow presentation, the best is to the cesarean section is done. Mentro anterior can be delivered vaginally, and best with the use of the forceps. The submentum hinges under the symphysis pubis, and the head is delivered. It is by the flexion, brow, and occiput. So this is about the different types of pelvis, and how this pelvis actually and the feto-maternal relation actually helps for the vaginal delivery. So this is the mystery. This is really the mystery, and I think I have completed. I think so. The different joints, and also the different types of the pelvis and how the mechanism is modified. And the grossly contracted, if it is a gynecoid, the same problem occurs. In grossly contracted, overall contracted pelvis, inlet contraction, and the mid pelvic contraction and outlet contraction. That depends on the size of the baby, whether even maybe the gynecoid, but if it is a small gynecoid, there may be. So according to the prognosis, we can say the bad prognosis in the anteroid pelvis, number one, most worst prognosis, and also the small gynecoid pelvis, and next in the anthropoid pelvis, and next in the platypoid pelvis. And so good prognosis gradually, best prognosis of the abnormal pelvis is the platyploid or flat pelvis. And next is the good prognosis in case of anthropoid pelvis, occipitoposterior, and android pelvis, the worst prognosis. So thank you all. Thank you. I so much of I have finished my topics. Thank you. Thank you. Thank you, Dr. Hapiju, Dr. Ashish, for giving me the scope to describe these terms are difficult for the postgraduate. But if you think it will be good, and you'll have to practice all the postgraduate. Thank you. Thank you.
Thank you
so much,
Abdullah.
sir.
Actually, we always want to explore more and more mysteries of the pelvis
Yes.
and the dummy doll. And this is really a vexing issue for the appearing postgraduates, appearing at the exam. So over and over, many, many more such episodes, we will explore one by one the different, nitty-gritty of the technical aspects of the maternal pelvis and the fetal skull. I always feel that the postgraduate teaching regarding dummy doll and pelvis is different from the undergraduate teaching. What we have been preaching from the undergraduate days is that everything is normal. I mean, the fetal head is completely flexed. There is no deflection. The pelvis is gynecoid type of pelvis. It goes inside, internal rotation, etc., etc. But what happens in the slightly abnormal, not abnormal, deviated situations, because all pelvis are different. And thank you, pelvis. Arupda, you have touched upon the classification of pelvis from the basic Caldwell-Molloy classification up to the slight deviations. You have highlighted the importance or non-importance of the coccyx in labor, and also the different aspects of the inlet outlet. So we will invite questions in the chat box, and interaction is possible. But in the meantime, I think our series of dummy doll and pelvis is continuing. We'd like to take more such issues which actually lies inside. It's like the footnote of a textbook. It is never written in the textbook properly, but they are actually taught by this one-to-one session lessons. So we'll take up all these issues. Thank you very much, Arupda. And now,
thank you, Ashish. Thank you, Dr. Hapijur. And also thank you, Dr. Ashok Kumar. He particularly wanted to the Dr. Hapijur regarding the shoulder dystocia. That is the shoulder distal and the macrophat-Vanover. So I have tried my best to make the understand by the postgraduate what happens.
Yeah, today we have understood the basics.
With the, definitely with the help of my Shobna, my better up. She also from side and behind has also helped me. Not here now. Ashish is Ashish classmate actually. Shobna is Ashish classmate.
Yeah,
that makes the demonstration sweeter. Anyhow,
that's the gynecologist.
Thank you so much, sir. I think that is so sir's passion is for teaching, and madam is always nearby in having
always.
Yeah. In future also we will take up this shoulder dystocia and other maneuvers differently. But today was the basis of how you can logically think about what to do in shoulder dystocia. Thank you very much, Arupda. Okay. So we will go to the next session, please.
Yes, sir. Correct, sir. Thank you so much, Maji sir. As you have told, we would like to have you in future again exploring in different aspect, as like Ashish sir said. We can have explore in different particular areas and taking in different aspects of the pelvis in incoming sessions. So now we'll move to our next session. That is the session is one of the most awaited, because depending on this session is also the quiz competition is based on. So this session is on case presentation. So this time we have with us students from the All India Institute of Medical Sciences, Raebareli, and they are having a case on pelvic organ prolapse. And the students, those that have prepared themselves very hard, is Dr. Aditi Keshwar Chaurera and Dr. Jaya Rahman. And they have been amply guided, their HOD, Dr. Vandana Verma. So we'd like to welcome both of the students as well as their coordinating faculty. We have the faculties, as always, the expert in this spatial area. So Dr. Ashish Kumar Mukhopadhyay, sir is principal professor, CSS College FOGSI, always there with us. Then we have Dr. Nirmala C. Madam is professor at Sri Mukambika Institute of Medical Science, that is in Kanyakumari, Tamil Nadu. Then we have another expert in the form of Dr. Manidip Paul sir. Sir is principal and professor, College of Medicine and GNM Hospital, Kalyani, West Bengal. We have Dr. Deepa Lukwani, madam. Madam is professor at Jaipur National University by Institute for Medical Sciences and Research Center, Rajasthan. So I'd like to request Dr. Jaya and Dr. Aditi to share your presentation, and would like to request all the faculties to take over from now, as well as request Dr. Arup Mazi sir, if you have time, sir, you can have also with us. Over to you, Dr. Jaya and Aditi, and to all the faculties, please.
Yes, sir.
You can introduce yourself and start with. Full screen?
Yes, sir. Yes. Good afternoon, dear sir and ma'am. I myself, Dr. Zoya Rahman.
Myself, Dr. Aditi Savrewar. We are from AIMS Raebareli, currently JR3.
I will be
See your
presenting.
presentation, but is there any presentation?
Please share the screen. We are not yet able to see, I think. Yeah. If you have any, you can stop share and again share if there is any issues. Yeah, now please go ahead again. Yeah, please make it PowerPoint show or the full screen. Yeah.
Perfect.
Go ahead. Go ahead.
I will be presenting the history part. Patient Mrs. X, 30-year-old female, housewife by occupation, educated till 4th standard. Date of admission was 25th of April 2025 and date of examination was 25th of April 2025. Married to Mr. Y, shopkeeper by occupation, Hinduism by religion, resident of Munshiganj, 12 kilometers away from AIMS Raebareli. Patient presented with the chief complaint of something coming out of vagina since 6 years, discharge per vaginum off and on since 1 year. Patient was apparently well around 6 years back when she complained of something coming out of vagina, insidious in onset, gradually progressive in nature. Initially, patient used to feel this on coughing, straining and doing heavy work, but since last 8 months, it comes out even on standing and walking. It was initially of small size and now it has increased in size, affecting daily life and activities. It reduces spontaneously on lying down. No need to reduce the mass for defecation or urination. Patient also has history of discharge per vaginum off and on since last 8 months. White in color, mucoid in consistency, scanty in amount, not blood stained, not foul smelling, not associated with itching. There is no history of abnormal bleeding per vaginum, dyspareuria or postcoital bleeding, burning micturition or fever, increased frequency and incontinence of urine during straining, retention of urine, constipation, incomplete evacuation and straining while defecation. There is no history of abdominal distension or swelling, chronic cough, chest pain or shortness of breath, joint pain, dislocation and subluxation, easy bruising, poor wound healing or blurring of vision, trauma, heavy weight lifting or backache, loss of appetite and weight loss. Obstetric history, she's married for 10 years, para 1 live 1, 9 years male, conceived spontaneously after 1 year of marriage, antenatal period was uneventful, labor pain started spontaneously at term and lasted for 8 to 9 hours. Normal vaginal delivery with episiotomy was conducted in district hospital with an average birth weight of around 3 kg. There is no history of prolonged labor, instrumentation, no history of any postpartum complications. She resumed her household activities after 1 week. There is no history of contraceptive use. Menstrual history, she attained menarche at 14 years. Her LMP was 18th of April 2025. Menstrual history is regular, 28 days cycle, 2 to 3 days flow, using 2 pads per day. Dysmenorrhea was present. Past history, there is no history of diabetes mellitus, hypertension, tuberculosis, thyroid disease, asthma, chronic cough or any chronic illness. No history of any surgery in past. There is no history of diabetes mellitus, hypertension, malignancy, and connective tissue disorder in family. Personal history, there is no allergy and no history of drug abuse. Functional history, bowel bladder habits are regular and sleep is adequate. Socioeconomic history, belonging to rural area, educated till 4th standard, income per capita is rupees 2,000 per month. Head of family is shopkeeper by occupation, belonging to lower middle class according to modified Kuppuswamy scale, using tap water. Dietary history, she is a vegetarian, taking 2 major meals and 2 small meals in a day. Using 24-hour recall method, total calorie intake is 1600 kilocalories per day. Total protein intake is 45 grams per day. Total calories deficit is 300 kilocalories per day, and total protein deficit is 11 grams per day.
Good afternoon, sir and ma'am. I will be presenting the examination part. On general physical examination, patient is alert, cooperative, and well oriented to time, place, and person. Her examination was done when she was sitting comfortably on bed. She is average built and nourished, well hydrated. She is febrile on touch. Her weight is around 56 kg and height 153 centimeter. So her BMI is 21.8 kg per meter square. There is no pallor, icterus, cyanosis, clubbing, or koilonychia. JVP was not raised. No signs of lymphadenopathy. Neither pedal edema was present. Vitally, she was normotensive and pulse was 78 beats per minute, regular, rhythmic, good in volume, no radial or radiofemoral delay. BP was 128 by 76 mm of Hg, taken in right arm in sitting position. Her respiratory rate is 16 per minute, regular. Respiration was thoraco-abdominal type. Temperature was 97 degree Fahrenheit at the time of examination. On breast examination, there was no lump. Nipple areola complex is normal. On thyroid examination, no signs of goiter, not any enlargement. Her spine examination was normal. No scoliosis or kyphosis or any deformity seen. On systemic examination, on examining CVS, S2 and S1 was normal. No added sounds or murmur heard. On CNS examination, higher mental functions were normal. Locomotor and spine is normal. Sensory and motor examination normal. On respiratory examination, the respiratory rate is 18 per minute. Bilateral lung fields resonant. Bilateral normal vesicular breathing sounds heard. No adventitious sounds heard. On per abdominal examination, on inspection, abdomen is symmetrical in shape. Umbilicus is centrally placed and inverted. All quadrants move equally with respiration. No dilated veins, scar marks, or visible peristalsis seen. Hernial sites were intact on standing and cuffing. On palpation, she is afebrile to touch. Abdomen was soft, non-tender, no mass palpable, neither organomegaly palpable. On percussion, tympanic note heard and liver dullness heard at 5th intercostal space. On auscultation, normal bowel sounds heard. On local examination, patient was examined in dorsal position with bladder comfortably full and parts were adequately exposed after her informed consent. On local examination, on inspection, on asking to fully stain, mons pubis normal looking with black dense overlying hair, labia majora is normal, episiotomy scar present on right mediolateral side, cervix as a leading point noted, approximately 5 to 6 cm outside the introitus, which is congested and edematous, a decubitus ulcer of 2 by 1 cm on posterior lip at 7 o'clock position seen, cystocele of grade 2 noted, no evidence of keratinization or hyperpigmentation. Vaginal rugosities are absent with lateral sulci present. Urethral meatus was normal, no urinary leakage on cuffing seen. After reducing the mass manually, no urinary leakage noted on cuffing, perineum appears normal and external anal sphincter is normal. On per speculum examination, after reducing the mass, the vagina is healthy, anterior vaginal wall, cystocele of grade 2 noted, cervix is congested and edematous, a decubitus ulcer of 2 by 1 centimeter on posterior lip at 7 o'clock position seen. On posterior vaginal wall, there is no rectocele or introcele noted.
I would like to interrupt at this place.
Yes, ma'am.
Go back to for the previous slide. Yes. So after reducing the mass manually, what was the, how did you elicit that there was no urinary leakage? What test did you conduct here?
Ma'am, we asked her to cough after reducing the mass. There was no leakage of urine seen.
So you asked her to strain. That was the supine reflex you asked her to elicit. Is that so?
Yes, ma'am.
Okay, go ahead.
On bimanual examination, uterus is retroverted, normal in size, non-tender, firm, and mobile. Bilateral fornices are free. Tone of levator ani muscle is good. According to modified Oxford grade, it is 5. Bulbocavernous reflex present. Anal wink reflex present. On per rectal examination, rectal mucosa is free. Anal sphincter tone is good. Rectovaginal fascia is normal. Perineal body normal. On PR examination, dress score was done. The resting score is 3 and squeeze score is 3.
Okay, so go back to previous slide. Previous to this. Yes. So what do you mean to say the bulbocavernosus reflex was present and anal wink reflex was present? What does it denote?
Yes, ma'am. The spinal root value of S2, S3 and S4, it is checked by the bulbocavernous reflex and anal wink reflex. So we elicit these reflexes to check the integrity.
So how do you elicit these reflex? Bulbocavernous?
Bulbocavernous reflex is checked by tapping on the lateral wall of clitoris and the contraction is seen.
So this is about the sensory reflex, isn't it? Of S2, 3 and 4. So the sensory or somatic reflexes are present. So this is how you elicit some neurological examination in this area. So both are reflexes for the somatic reflexes. Right? Yes. And anal wink, how did you elicit this?
We tap around the perineal body, the perineal perianal skin and contraction of
this is at the mucocutaneous junction. Yes, if you say it precisely, it will be at mucocutaneous junction of anal mucosa. Anal mucosa at that level of anal sphincter.
Yes, ma'am.
So
may I ask one
denote? Yes.
Yeah. Actually, how does it help us in your management and other things? And why can you elaborate on why do you want to check this? And how does it affect your management?
Ma'am, the neural factor, that is S1, S2 and S3, the intactness with the pudendal nerve intactness we can see by these reflexes, ma'am. There is a nerve defect if they are not present.
Yeah, that will try to help you in finding out etiology rather than, is that so?
So this shows your obstetric injuries that have occurred to the perineal region. So that is why you check how much obstetric injuries while childbirth has occurred, or is it intact, right? So this is how you elicit the causes or etiological factors associated with the prolapse, if you are thinking about that.
That's the answer. Okay, continue.
Continue.
Yeah.
On pelvic organ prolapse quantification, the AA point is lying at 0, BA point lying at plus 3.5, C point at plus 6, Genital hiatus at 5, perineal body is 4 cm, the total vaginal length is 9 cm, AP point at -3, BP point at -3, and D point at -2. So this, according to the POPQ system, this is the stage 3 defect with anterior wall defect, that is cystocele with leading point C.
So you don't have any posterior compartment defect in this patient.
No, ma'am.
So according to your POPQ, you just stage it and just define what is the central compartment defect, anterior compartment defect, and posterior compartment defect.
Ma'am, there are three compartments, anterior, middle, and posterior. The A, BA point are from the anterior, AP and BP from the posterior, and we have 3 more fixed point with that C and D. The A point is lying 3 cm from the hymen, so it is normally at -3 position. If it is at -3, it is a normal position. Any deviation from that point, it denotes the anterior compartment defect, that is urethrocoele. The BA point, it above the -3 till the C point or +3, it can come out. It denotes the cystocele. C is the cervical point. It is at minus.
So your genital hiatus appears to be 5 cm here, whereas perineal body is very much intact and shows. And levator NI test according to Oxford classification, what was the grading of that?
Grade 5, ma'am. That is a strong.
It was strong. Okay. Okay, go ahead. Continue. So it is stage 3 for central compartment, along with cystocele.
Yes, ma'am.
What is simplified POPQ?
The fourth one.
What is simplified POPQ?
The fourth one. Talk about the new POP.
You have shown us the 9 quadrants POPQ, right?
Yes.
Yeah. Because of the so many juggleries, it has been simplified, so that each and everybody, not only the research situation, not only the medical college, even in the remotest part of the any country, even in remote village also, they can use this. So it has been simplified. What are the components of that? It has only 4 components. Can you name those? It's have only BA, BP, C, and D. That's all. Understood? It's already there in the ICOG ICS common terminology forums. Is already there. Okay, carry on.
Do you know about any other classification system about grading the prolapse central compartment?
Yes, ma'am. Shaw's classification is there. Beden-Walker is there. Beecham is there.
Yes. So, what do you commonly use at your institute and department?
POPQ we do, ma'am.
Yes, POPQ is globally accepted international standards, and it can be reproducible, right? So that is why we use POPQ. So, do you know about the simplified Beden-Walker? How does it help?
It is divided into 4 grades, ma'am.
Yes.
Grade 0 is no prolapse, and grade 1 is prolapse up to halfway past hymen. Grade 2 is prolapse till hymen, and grade 3 is prolapse past hymen, past halfway the hymen, and grade 4 is entire the uterus lying outside the hymen.
Okay, go ahead. Continue with your presentation.
Now the summary part. Mrs. X, 30-year-old, para 1 live 1, belonging to lower middle class, presented with the chief complaint of mass protruding per vaginum since 6 years, associated with discharge per vaginum off and on, with no urinary or bowel complaints, with 1 vaginal delivery at district hospital with early resumption of household activities, with no history of prolonged labor or instrumental delivery. She has no history of chronic cough and previous surgeries. On examination, BMI is 21.8 kg per meter square. No abnormal finding on abdominal or systemic examination. On vaginal examination, a decubitus ulcer of 2 into 1 centimeter on posterior lip at 7 o'clock position was seen. Anterior vaginal wall cystocele 2+ was noted. Third degree cervical descent with no rectocele or enterocele noted. On straining or cuffing, there was no leakage of urine per urethra. So our differential diagnosis is uterovaginal prolapse, anterior vaginal wall cyst, Gartner's cyst, fibroid polyp, chronic inversion, congenital elongation of cervix, and large malignant growth like CA cervix.
So, how do you differentiate between congenital elongation of cervix and obstetric cause for cervix? How will you differentiate? Here you haven't mentioned any fornicial length.
Ma'am, congenital elongation of cervix, patient will present at a younger age and there will be deep fornices and...
So your patient is a younger patient?
30 years only, she's 30 years.
Your patient is a young patient.
And
Then?
Intracervical length will be also large in congenital elongation of cervix.
What is the difference in both the elongations? How will you differentiate between a congenitally elongated cervix or in a prolapse cases which is having a later acquired causes? What is the difference in the cervical length in both the cases?
Ma'am, in a congenital elongation, the infravaginal portion of cervix will be large than the supravaginal part of cervix.
Yes. So how will you differentiate between both the things?
We can use a uterine sound to measure the uterine length.
Okay. Then?
And we can see the uterine size also, ma'am.
How?
By bimanual palpation, ma'am.
See, there are two portions of cervix. One is supravaginal and the other is portiovaginalis, that you call as infravaginal. So is there any difference in the lengthening of the part of cervix in both the cases, in a congenital and acquired causes of cervical elongation? See, you never know whether this patient was already having a congenital elongation of cervix or not before her first delivery, isn't it? So now she has presented, so maybe that has predisposed her congenital elongation, isn't it? So how will you differentiate both the things?
You have already given the answer. You just need to describe the points. You have taken the uterine sound, right? Uterine sound can be used not only for the inside the uterus. Madam has given you a clue, right?
Uterocervical length we can measure.
Yes, yes. What you can do?
Uterocervical length, sir.
Now that to putting the sound inside the uterus. Without putting inside the uterus, still you can use the sound. You can differentiate this.
To measure the length of posterior fornix and the cervix.
Yeah, fornix you should measure. There will be difference, right? Congenital elongation, you will find out the long posterior vaginalis, but other prolapse, the fornix will be shallow because these are supravaginal elongations. You should give answer those two, madam.
So you have been given all the hints related to this, isn't it? In the congenitally elongated cervix, what happens? The portiovaginalis will be long and there will be deep fornices, isn't it? And wherein the acquired causes, what happens? Those ligaments which are lax on the supravaginal portion. The cervix is dragging down because of the acquired causes. So the supravaginal portion of the cervix will be elongated, isn't it? And there the portiovaginalis will not be elongated. That is how the fornices will be shallow only. It won't be a deep one. So that is quite evident in your per speculum examination. That you can very well elicit. The uterocervical length, yes, you have to take and according to uterocervical length, the overall elongation of cervix will be evident, but you won't be able to appreciate which portion of the cervix is elongated, isn't it? But doing a simple per speculum examination thoroughly will tell you which portion of the cervix is elongated. You have taken in your history part ruling out connective tissue disorders, isn't it? The
Yes.
joint easy joint dislocations and easy bruising of the skin. So these are all connective tissue disorders, signs of that. You have already ruled it out that she was not suffering from any previous disorders showing any connective tissue disorders. Right. And in your per speculum examination, if the fornices are not deep and the portio vaginalis is not long, so the congenital elongation is already ruled out, isn't it? Now you go ahead with the differential diagnosis.
So our provisional diagnosis is 30-year-old para 1 live 1 with uterovaginal prolapse stage 3 POCQ.
Good afternoon, students. Very good presentation. I have few comments for you. The first comment is the menstrual history normally should come before the obstetric history. That is from the history part. Secondly, I was looking for the per speculum examination in the local examination. Have you mentioned about the fornices? Is there any mention about the fornices there? Fornices are deep or shallow or something like that. And the second point that you must note is the length of the cervix. You have to measure it also. The portio vaginalis of the cervix must be measured. You know, if you can do the POPQ, you can measure the portio vaginalis also. These two information are missing here. Do you think that they have importance in management in future? She's a young lady.
Yes, sir. Deciding the type of surgeries.
Yes. Apart from the compartment or compartmental defects, we need to see what is to be done with the uterus, or rather more specifically with the cervix. The cervical length.
Go to the previous slide before in per speculum. What did you write? Yes.
Yes, they have written anterior vaginal wall, cystocele, cervix is congested and edematous.
Yeah.
But no mention about the lengthening of the cervix or elongation of the cervix, nor there is any measurement. So I think that is needed here.
Yes.
Okay. And third point is I'd like to mention is that in a clinical presentation, the provisional diagnosis comes first and then the differential diagnosis. You cannot have the same differential diagnosis as the provisional diagnosis. For instance, in this case, the provisional diagnosis is uterovaginal prolapse. Go to the differential diagnosis slide. Yes, this should go later after the provisional diagnosis.
Yes.
And the first diagnosis that you have written over here, uterovaginal prolapse, that is the provisional diagnosis. So you need to bring the second next slide here, and you should delete uterovaginal prolapse from the differential diagnosis.
Yes, sir.
Differential diagnosis is other than what is your provisional diagnosis.
So let us discuss here, how will you differentiate a cystocele from anterior vaginal wall cyst?
Ma'am, anterior vaginal wall cyst is reducible. Is not reducible, while cystocele is reducible.
And what are the other tests you will elicit? What are the other inspection part? On inspection part, what did you see?
Viscosity.
In cystocele, differentiating a cystocele and anterior vaginal cyst.
Ma'am, rugosities will be present.
Viscosity.
What are the way? Yes,
What
sir.
is support? What is support test?
Sorry, sir.
What is support test? SUPPORT. Support.
Support.
What
Yeah,
is
yeah.
support?
Support.
What are the different types of cystoceles?
They have mentioned cystocele grade 2. How do you grade
No,
cystocele?
no, not that one. There are other classifications there.
No, I'm asking,
There is
this
a
is a
central
different question.
cystocele of-
This is a different question, along with Dr. Monidip Pal's question, that how do you grade cystocele also?
Sir.
Did you heard about the central cystocele, paravaginal cystocele?
that is, yeah.
So, yes or no?
Yes.
Yes,
Sir.
sir.
Then how to differentiate between these two?
So there will be sagging of lateral fornix in paravaginal cystocele,
Sulci will be absent.
and midline sulci will be present, but lateral sulci will be absent.
So there is a big
What about-
mass coming out through the center. How can you say that it is central or paravaginal? Actually, defect lies where? In the central cystocele and penicillin. Where the defect lies, in which case?
In central cystocele, defect lies in midline defect. It is midline defect.
Paravaginal?
Paravaginal, it is lateral defect.
Laterally where?
In
Sir,
middle
fascia.
Middle fascia?
No, sir, lateral paravaginal fascia, there is defect in paravaginal cystocele.
No. Array, this is the, what is the fascia name here? What is the name of the fascia?
Arcus
arcus tendinous
fascia.
pubis.
That is a arcus tendinous fascia, which is the lateral vaginal wall, right?
Yes.
But which touches over there? On the anterior vaginal, what fascia is there? What is the name of the interchangeable fascia in the anterior vaginal wall?
Ectocervical fascia. It's from the
Either you
previous-
can say vesicovaginal fascia or pubocervical fascia. Either of the name you can say. But for me, I prefer to say the vesicovaginal fascia because it's easy to remember. Anteriorly vesicovaginal fascia, posteriorly rectovaginal fascia. But anyway, whatever you can say like. So now the anteriorly you are dealing with, so vesicovaginal fascia is going and touching to the laterally to the arcus tendinous fascia or the white line, right?
Yes,
Yes,
So
sir.
if there is a detachment in that area laterally, then the paravaginal cystocele develops. And your support test helps you to distinguish between these. You can simply just put a sponge holder, open the two prong, put it to the lateral sulcus, right? And lift it upwards and forwards. The bulge will go away. Then you ask the patient to strain. If the bulge reappears, that means the problem was the center, because by putting that one, trying to restore the normal anatomy. That means the lateral defect was been corrected artificially. So the paravaginal cystocele will not come back. But if it come back, that means the defect was not lateral, it is in the central. So if the bulge come back, that means central cystocele. Very easy. Understood?
Yes.
Now, Dr. Ashish's question, how do you grade cystocele?
You have done that grading, so you must have followed some method.
Bulge of most anterior part above the introitus is grade 1. Grade 2 is most bulging anterior part at the introitus, and grade 3 is below the introitus.
Do you observe any sulci and anything on the anterior vaginal mucosa over the cystocele and then grade?
Sulci are not mentioned in their examination finding also.
Yes.
Which is the most prominent sulci in the anterior vaginal wall that we observe? Anyway, so it should be mentioned in your exam finding and add those points. Okay. So any examiner has to say anything about the history part?
Yeah,
And then,
actually,
if
I
you
would
have,
like that one more point, they should ask about how it affects their quality of life and also psychological distress also. These are the points which is also important when we take the history. The thing is, can you tell, that's regarding the history. And then for the sake of the students, postgraduates, can you tell us how you find out the tone of the levator muscle? How exactly you demonstrate the tone of the levator muscle?
Ma'am, 2 to 3 centimeter by inserting in dorsal position, by inserting 2 fingers inside the introitus, 2 to 3 centimeter away inside from the hymen. We ask patient to contract the muscle. We check at 5 and 7 o'clock position.
Oh yeah, that's important. Yeah.
Now, how do you place your fingers? Like this or like this? Your point is right.
Yeah, your exams, you may be asked to demonstrate, and you should be able to know how to show it. This is one skill where you have to show.
Yeah, and it's a skill.
CBME, yeah. Yeah, CBME.
So the fingers can be placed either like this or like this. Which one do you prefer?
Have you done in your patient?
Yeah, they have done it, but they are somehow. See, this part only feels, no? This part doesn't feel.
Dorsal or ventral? Which part of?
So this part, like this.
So these are two things that you have to take care while one thing, how to elicit levator and eye tone. The other thing is while grading cystocele, you have to mention about all the sulci on the anterior vaginal wall. Submeatal sulci includes into that, because you have to, sometimes a patient presents even with erythrocele. So you have to mention about.
Also, the rugosity is also important.
They have mentioned about rugosity, I think.
Rugosities they have mentioned, yeah.
They have mentioned, yes. So after provisional diagnosis comes the differential diagnosis, which I think we have discussed. Dr. Deepa, would you like to proceed about the management, or Dr. Monideep or Dr. Nirmala, anyone?
Yes, let's ask them, how will you proceed in this patient? This patient has presented to you and you have completed the clinical examination as of now. How will you proceed with this patient?
Ma'am, there are two types of surgery management we can do.
Before going into surgery, do you like to do some investigations?
Yes, sir. We will just do the routine investigations like CBC, LFT, RFT, PT-INR, ABO-RH, TSH.
Go to specific investigation. How will you proceed? Management includes investigations and treatment.
Yes, and
the pre-op investigations and routine investigations and ultrasound whole abdomen to rule out any hydronephrosis.
Dr. Zoya and Dr. Aditi, my request to you, avoid using abbreviations in the examination, CBC, TVC, and etc., etc. You will mention the full sentences, okay? Full sentence. Avoid the abbreviations as far as practicable. This irritates many examiners. Yes, the CBC, LFT, KFT, TSH, and yes, DVC and CBC and CTC, etc. These things are not to be used in examination. Okay. So, as Dr. Deepa has asked you about specific investigations, but routine investigation, why do you do these routine investigations? Any justification?
Sir, we will proceed with the surgical management as it is hampering her day-to-day life and with her willingness also. So, or pre-op investigation we will do with chest X-ray and ECG also. Sorry, ECG, and with one pap smear we will do, and then we will proceed.
Okay.
How will you take their informed consent, and how will you counsel this woman? Because you cannot take decisions on your own. It has to be an informed decision. So how will you counsel and take an informed decision?
Actually, you have taken for granted that the surgical treatment is the only
surgery. Yeah.
Okay. But before that step, you need to have a counseling with the woman that there is medical management, either it is ineffective or it is not to be curative in its true sense. So that counseling, after that counseling, that is why Madam asked you this question. that the decision of surgery has to be taken all right, but with the consent of the woman. Okay. And then comes the question of the routine investigations. Because by that time, you haven't yet decided about the surgical management, right?
Many a times. Yes,
certain
yes.
conditions where you do not need the surgery,
Yes.
also by pelvic floor exercise or something like that, that is possible. Not in your case, but in other cases, it may be possible.
But even in this case, if that patient wants to go for the second pregnancy and she just want to defer her surgery till her next pregnancy is done, so it's not necessary that you have to go for surgical treatment only, isn't it? You have to do the proper counseling. What is the situation and how far would you be able to do her treatment at present, and how her future fertility is preserved with all those treatment that you are going to do.
And
So
the chance.
and the patient has to take the decision by herself with in a discussion, a free discussion with you. So that is why counseling is extremely important. And then comes the feasibility of the routine investigation. By the way, in your routine investigations, if you call it routine before operation, even then the serology test must be done these days. That I cannot find here.
So viral markers we have written.
कुछ सुनाई नहीं दे रहा है. Cannot hear you.
Sir, viral markers we have written that serology, HBsAg, HIV and anti-HCV is non-reactive.
Okay. Okay, what about HIV? Yes, you have written. Okay, HBsAg, HIV and anti-HCV.
Acha, what about you in your description, there is something you've written, the cucubitus ulcer, right?
Yes.
But forwards, you want to go for surgery, because how you can do without ruling out what is this ulcer? It may be or may not be cucubitus ulcer. You have not described the ulcer properly.
Yes, sir. Sir, it was present on the most dependent part, and we have taken the pap smear. It is negative for intraepithelial lesion or malignancy, and it was not any other ulcer on the lateral side or any suspicious was there. So biopsy is not done.
No, what is the normal management for a cucubitus ulcer?
So it was.
Why does it occur? Why does it occur?
So due to venous stasis.
Fine. So now then what is the management?
So, management is reduction of prolapse, which can be done by packing or pessaries.
Absolutely. You should do a moist vaginal, not only packing, moist vaginal packing. That moist may be anything else. In our days, in our children, when you are students, that time glycerin, those surgeries are there. But nowadays it may not be available. At least you can do the povidone, whatever. But it should be a moist vaginal packing. And how long you should wait? Normally, what's happened? What the packing does? This reduction, what it does?
It reduces the reduction on also edema
congestion. It reduces with the healing of ulcer. That is hydroscopic in nature.
So what will happen? Absolutely, what will happen to the decubitus ulcer? It will get healed up.
Healed.
So you should give, and how long you should wait for seeing that whether it is healed up or not?
So daily packing should be done until the ulcer gets healed.
But that should be the time limit, right? What is the time limit?
At least for 15 days.
Yeah, 10 to 14 days. So beyond 2 weeks, if the ulcer still doesn't get healed up, what should you do next?
Then we will suspect for any malignancy, and we will go for biopsy.
Absolutely, that should be a primary protocol. You are dealing with the ulcer. If it doesn't get healed by 2 weeks, if you do the biopsy, something different come out, your all management will be different.
Is there any role for estrogen creams in your patient for this an ulcer?
Yes, ma'am. If there is atrophic vagina, then estrogen cream application 2 to 3 times per week initially, then once weekly for at least 1 month we can tell the patient, and before 2 weeks before the surgery we have to stop it.
Now the ulcer has healed. How do you proceed now? And you didn't tell us about the options available for her And how do you counsel and how to get the consent also? Because you cannot just straight away jump into a surgery.
No, actually, there is a technical point here. You see, it takes a long time for the decubitus ulcer to heal completely, isn't it? And there is a tendency of ignoring the decubitus ulcer. That is also unfortunate. It should not be done. And it should be adequately, tested and tried, and then management should be initiated. But can we discharge the woman by putting a pack inside and ask her to come back after 2 weeks? 2 weeks is a long time for her to be admitted in hospital, isn't it? So there will be logistic issues on the part of the woman.
So we can counsel her for pessary insertion.
So simple elevation of this thing or reduction helps a lot, and keeping the area moist. That's all you have to do. If you can adequately explain this to the patient and her relatives, then maybe it is possible at home also, avoiding hospitalization.
So tell me, the question is now, what do you think is the etiological factor possibly for this patient?
Ma'am, maybe due to the early return of household activities after delivery and poor nutrition of this patient.
So do you think is there any role of giving a good protein diet along with the good physiotherapy? Is there any role of giving this therapy to this patient?
Yes, ma'am, it can strengthen the pelvic floor muscles.
She is a young patient. According to you, levator ani tone is good, perineal body is good.
What happens to the uterosacral and the Meckenrod's ligament when the cervix is dilated, fully dilated? What happens to it?
There is stretching of uterosacral and cardinal ligaments.
I'm trying to give you a clue, then you can plan.
So tell us the management options for this patient. You just told us we are just planning for surgery. You have to do a complete workup with specific investigations. What are the defects underlying along with the central compartment defects, and what all you need to correct even if you are going for surgery, and if the patient is deferring her surgery till her next pregnancy, then what are the options for her?
Yeah, but before going into surgery, do you have any scope of ultrasound here in your case?
Urological studies also in patient. She has no incontinence, but do we have to advise any urological tests for her to find out any occult stress urinary incontinence? Or history-wise, there's nothing. Is there a role?
Yes, sir, to diagnose any occult stress urinary incontinence
or any detrusor muscle overactivity, so that we can differentiate between them. So urodynamic studies are advisable in that cases.
What urodynamic studies you prefer to do? What urodynamic studies? That is what specific investigations are all about. What do you do in a specific investigation and urodynamic study? There are so many urodynamic studies for different patients.
Have you done this for your patient?
No.
No, sir. She has no complaints. We have advised ultrasound for her.
They advised ultrasound. Okay, what are the ultrasound findings?
Uterus was normal in shape and echo texture. Endometrial cavity was normal. Bilateral adnexa is normal. Bilateral kidneys is normal with no hydroureteronephrosis.
We are not mentioned about urinary bladder here.
And the levator ani also, that you can actually diagnose by your defects, you can diagnose by the ultrasound.
And the cervical length also, no? Cervical length, I'm really worried about cervical length. Neither clinical finding nor ultrasound is there to find out the length of the cervix, which has got a management this thing,
Is it important to know cervical length exactly before proceeding for any kind of management, whether it is conservative or operative?
Yes,
Plan
yes.
for the what type of surgery?
Is it important? Why is it important? You should know about it. Now speak it out.
Ma'am, to plan for
We will plan the surgery accordingly.
and patient will also have infertility, can have infertility issues due to long cervical length.
Okay. Second thing, in operative procedures, how does it help to know about the cervical length? How does it help you?
Ma'am, as there are two to three types of procedures which can be done: Fothergill's and sling surgeries. Sling surgeries are advised when a patient have stage 1 or 2 stage 2 1 and 2 uterine prolapse with the uterosacral length of less than 5 inches. And it can be done as the patient is desirous of pregnancy, but there is also one of the surgical options like Fothergill repair, in which amputation of cervix is done, but the patient may have like preterm labor, second trimester loss, cervical stenosis, these complications.
What do you do in Fothergill's? Do you know about the what do you do in Fothergill's?
Ma'am, preliminary DNC dilatation is done. If patient has abnormal bleeding, then curettage is also done to rule out any endometrial pathology. Then amputation of cervix followed by plication of McEnroe ligament.
So this is important. You are reducing the length of cervix, isn't it? Cervical amputation is done, isn't
Without
it?
knowing the length of the cervix.
How will you do that? How will you decide?
Ma'am, we will measure the uterocervical length and cervical length by uterine sound, and then we will decide accordingly how much to amputate the cervix.
So
No, your ultrasound says uterus is normal. That means 7.5 centimeter. Now, would you go for the cervical amputation in your case? She's 30 years.
No, sir.
No, sir. Okay. So
Now-
here
now-
a lot of counseling goes on here also.
As she is desirous of future pregnancy, so keeping her wellness in account, she is ready. We have counseled her, we have given her conservative options and operative options, so she has opted for the sling surgery.
Sling surgery.
There are more chances of abortion, preterm labor, cervix dystocia in the Fothergill's.
Okay. Now, that apart, would you like to recommend aerodynamic studies? You said about just a few minutes ago. Would you like to recommend aerodynamic studies in these cases, this type of cases? I want opinion of Dr. Monideep Pal also and the external examiners.
Okay, let them give answer, then I will tell.
Let them answer first.
Sir, we routinely don't do urodynamic studies. If there is stress urinary incontinence or any urinary incontinence, so then we will further proceed for the urodynamic studies.
Yeah, you are correct. As per the latest NICE guidelines, we don't routinely recommend these urodynamic studies, even for starting the urinary incontinence treatment also. But if you are going for some SUI operations,
yeah.
especially past one anti-incontinence surgery failed, those careers definitely important. But otherwise, detailed urodynamic studies are not mandated. For initial starting and for the overactive bladder treatment, no need. For SOA also, initial studies, they said that no need to do the routinely one. But anyway, if you are thinking of going for the here also, if you have for the prolapse cases, definitely it's not mandated. As a particular your case, there is no SOA complaint or no other urinary complaint. So for your particular case, no need. By the way, I just want to know one thing. That you said that you can go for the given case of slings and others. What is your opinion about the laparoscopy pactopexy or laparoscopy robotic, means the minimal invasive pactopexy operations or the sacrosteopexy?
So we can also do that also in this patient.
Yeah, that's true. Because as your case says that it is not an ideal case for the cervical amputation. So FOGSI may not be a very good choice for this particular case. So rather, if you are and you have a good component of the anterior compartment. So what's happened to the FOGSI? You are fixing the mesh to the anterior area, right? So when you elevate it, it itself correct quite a good amount of the anterior compartment collapse. After doing that also, if still some amount of cystocele left behind, then you can think of doing a small cystocele repair. But sometimes it's happened that as because the mesh usually get shrink afterwards, around 1 to 1.5 centimeter they get shrinks. So even if you in the find that little bit amount of left behind, but if you do 2 sittings, that is better, because while you see your follow up, the whole anterior compartment may goes up after doing the FOGSI. But still, if it is left behind, the second sitting you can do after a few weeks or something like that. Second part is that my opinion. Another question I'm asking: can you do sacrospinous hysteropexy in this case?
Yes, sir, we can do in this case.
You can do? Okay, fine. Good answer. Now tell me, sacrospinous called hysteropexy. Through which compartment you will approach to the sacrospinous ligament? Anterior compartment or posterior compartment?
Posterior compartment.
Posterior compartment?
Yes, sir. Yes.
And your problem is in the anterior compartment. What is the inherent problem with the this sacrospinous fixation, either hysteropexy or colpopexy? What is the inherent problem with this operation procedures? What's happened to the anterior compartment postoperatively? What is the common complication of sacrospinous fixation?
Cystocele doesn't get connected.
It changes the anterior vaginal angulations. As a result, there is a recurrence of cystocele. Other things may not develop or may be developed, but the chance of cystocele is higher. So as your case is a good component of the anterior vaginal compartment, in this case, if at all you are thinking, because it is not an ideal case for the sacrospinous fixation, right? But still, if you at all think to do the sacrospinous fixation, sacrospinous hysteropexy, your approach will be better go through the anterior approach. So that initially you're doing some dissection over there, number one. And number two, while you're bringing out the sutures through the anterior compartment, in that case, you'll be doing more, the fixation will be more towards the anterior part of the uterine areas, cervical areas, right? So the more of the anterior compartment taken care of, right? Next question is that if you are approaching towards the through the anterior compartment, what is the better instrument?
So usually Mia hook is used.
Which one?
Mia hook is used for sacrospinous.
No. Mia's hook has some inherent problems to approach to the anterior compartment. It's a very good instrument while approaching towards the posterior compartment. Very good instrument. But anteriorly, if you want to approach, yes, you can approach. There's no harm. But I say that what is the better instrument?
Suspension.
Capio's device. Okay, CAPIO apostrophe S. Capio's device is a very beautiful instrument, and as because you are going to the anteriorly, maybe dissection is a little bit difficult. It's not like the anterior compartment, posterior compartment, and moreover, retrieving is very easy. Though it is a single use, but it is if you have the facility of the Capio devices, it is a better instrument if you are going through the anterior compartment. Okay, others please ask the questions.
No, actually, I will have my opinion here also. You see, I won't recommend sacrospinous fixation in this case. That apart, the Mia hook is less expensive, but Capio is quite expensive, and it is apparently if we do justice to the instrument, it is disposable, isn't it? I don't know how many of our medical colleges can afford that, or institutions can afford that. But yes, specialty institutions where they are practiced routinely, they can use that. But here, I think that if the patient, we can provide pectopexy, that is a good option. That is a really good option for this particular woman. And I really agree with Dr. Monidipal that this case is not really ideal for the FOGSI type of operation. FOGSI type of operation, you are cutting through the cervix, I mean, amputating the cervix. So always very important to keep some functional cervical tissue there. Otherwise, there are a whole lot of reproductive difficulties later on later life. So which is very, very, disturbing for the woman. So I think that pectopexy, laparoscopic pectopexy, if you can, that is a good one. But even after pectopexy, as Monideep said, there are many cases where you may need, after some time, repair of the cystocele, residual cystocele, I should say. And I wonder how many patients will come back to you for that, isn't it? So that is an issue in our country. So there are certain problems in every field.
The role for as sir has said, what is the role for laparoscopic suspension, suspension in this patient? And what type of patients will you advise that?
Which one?
Laparoscopic methods of uterine suspension. Laparoscopic methods.
Sacrohysteropexy.
Yeah. And also even that now they are talking about the round ligament plication and making it in the position and sacropexy and all that. What is the role for all that?
These are basically good for the posterior compartment defects, but I think anterior compartment defects, I don't know how much is the effectiveness. I have never seen that or done that.
One of the procedure, abdominocervicopexy, where you use the native sling procedure, isn't it? Yes, so that is one of the option, depending upon the patient's like if she wants to conceive, maybe she's not trying for last 9 years, and that is why she has not conceived. So many couple, they just are satisfied in one child norm, isn't it? So it all depends upon your counseling. So how much fertility she wants to preserve, and the problem, the pathology is troubling her day-to-day life. So what does she want? So you have to do a proper counseling. And regarding urodynamic studies, yes, this patient is not having any urinary complaint. So a simple ruling out of any UTI, or along with it, if it is an ascending UTI, so you have to go for urinary culture, and in ultrasound also you have to look for the thickening of bladder wall, or is there any component of cystitis. So you have to treat along with the decubitus ulcer, you have to treat that as well before planning for any definitive surgery or a conservative management for this patient. There are so many patients who wants to conceive and they try for PFMT, pelvic floor muscle training exercises along with good protein diet, and once they conceive, they deliver the baby, and then they go for definitive surgery. And if this patient has already decided that they don't want to go for further fertility, then they can be there are so many options for them. So there are so many modifications for the rectal sling surgery even, right? So there are so many options for this patient, preserving her uterus, preserving her fertility option, future fertility options, and menstrual abilities, depending upon her cervical length, that was deficient in your examination. So there are so many options available for this patient. So sacrohysteropexy, as Dr. Ashish already stated, that is mainly supportive to posterior defects. And sometimes we just extend a Y-shaped mesh, putting it anteriorly, but still the anterior compartment defect is not accurately resolved with this. So we are having for this abdominal wall or native sling surgeries with some modification. So that is for the anterior compartment defect exactly, and the cervical elongation will be taken care of with that procedure. So rectal sling in young patient that is having a good strength, so it can be applied for this patient.
I want last question: is prolapse preventable? Is there any preventive measures that you can advise to a woman?
We can advise pelvic muscle floor training exercises.
When should it be done? When should it be done? Can you tell me any antepartum, intrapartum, or postpartum measures or interval measures that can be taken to prevent a prolapse?
Especially postpartum
period, we can tell her. And
when should you start it? You are the junior resident taking care of the patient, and when should you should tell me how you will counsel the patient to prevent it. because you all know that the ligaments and all those get stretched and torn during pregnancy. You want to rehabilitate it properly. So what advice will you give her so that it's to a large extent you can prevent prolapse? When should she start
So in the postpartum period and not in the antenatal period?
No, not in the antenatal. Even antenatal, not in antenatal. Then what about the body weight? This patient is, her BMI is fine. And now they are coming with a lot of things about the role of obesity, lifestyle, and then pelvic floor measure. So in the postpartum period, what advice will you give her? And when should she start doing the exercise and all?
Okay, here is a viva voce question for the students, rather.
Yeah, this is usually a question that's asked in the exam.
Yes. And whether this pregnancy is more damaging or the labor is more damaging. Yeah. I mean, ultimately, etiopathogenesis of prolapse, which one is more damaging?
Yeah, actually, when in 10 centimeter dilator, naturally they say the uterosacals get stretched. Then when the perineum is bulging, the levator is also being stretched and sometimes torn. All these are, most of the things it can be reversed by this exercises. So that's why it's important for a postgraduates who are taking care of the obstetric patients, intrapartum and postpartum period, to have a proper conducting of the delivery. But time doesn't permit that. Intrapartum care is very important, especially in the second stage of labor and conducting delivery, and the postpartum rehabilitation. All this advice and how to properly protect the perineum.
I think we had a thorough discussion on this. Sorry, madam, because we are now finishing time. Yeah. And I'm happy that the students like our years never came up with the management option of a vaginal hysterectomy pelvic floor repair. That is, they haven't said that. I'm very happy at that. And because they have, over the years, our students have understood the importance of preserving the uterus, preserving the fertility, particularly in younger women, and also taking women's choice into consideration. So thank you very much, all the examiners and both the students. You have done wonderfully well. I think you have passed with flying colors. There is no problem about that. And then if anyone wishes to say anything, I'll close this session because we are having another session coming up next.
Thank you, sir. Thank you so much for the wonderful opportunity. The students are excellent.
Yes. Thank you, sir. Thank you. Thanks to Dr. Ashok Kumar, Dr. Hafiz, Dr. Ashish, and all the my colleagues and students. You have done so well, and thanks for making me a part of it. Thanks a lot.
Dr. Hafiz, thank you so much for making.
Yeah, thank you, ma'am, for sparing your valuable time.
Thank you.
Thank you, Hafiz. Thank you, Ashida. And both the students are excellent. They're
Bright future. Wish bright future for them.
Thank you so much, all the faculties and all the students and AIMS Bareilly, the students, Dr. Zaya and Dr. Aditi and Dr. Vandana, they are head of the department, for your sparing your time for ICOG. And I hope for the students, it will be it was a great opportunity, as well as this will give you lots of confidence for future presenting in the national platform. Thank you so much.
So already Dr. Meena Samant is here. Please introduce her.
Meena madam is already in line. Yes, sir. Ashish sir, please go ahead.
Nice meeting you, Dr. Meena.
Good afternoon, sir.
Good afternoon. It's always a pleasure seeing your smiling face. And
yeah, ma'am is always. Yeah.
Today you are supposed to take up a very important session for our postgraduates. That is the examination, obstetric examination. I mean, abdominal examination to be more specific. I would have been happy if I have given this topic, but a very, very limited and very focused topic. I suppose that Dr. Meena Samant will do full justice, and here is your time.
Thank you so much. Sir, Meena ma'am is a senior consultant and HOD, Kurzi Holy Family Hospital, Patna. So, because the students many times, and this is the very basic thing as well as very important thing for the examination, and we expect none of the students make any mistake. So this will be an important session for them. So over to you, Meena madam.
So thank you very much. My connection was giving a little trouble. So in case I fail, I have Mr. Ramnath to help me out with the this thing. So I hope my slides are visible, my screen visible.
Yes, it is visible, and you are audible.
Okay, thank you. So I will be focusing on the methods of obstetrical abdominal examination, as sir has just pointed out. First thing is why we are going to do this examination. We are going to assess condition of the mother as well as the baby. How's the baby growing? What is the size, the lie, the presentation, attitude, engagement, the well-being of the baby, whether we can hear the FHS or not, and some more things may be added to all that. So as we are examining the patient, we always have to be mindful of the dignity to the patient, provide privacy, explain the procedure and the need why we are doing it, take a verbal consent, ask patient if they have any pain before proceeding, because we're going to be careful about that. We have to maintain hand wash. We have to see that the patient has emptied her bladder, expose the abdomen from xephisternum to the pubic symphysis, cover above and below where appropriate. Ask the patient to lie in the supine position with head of the bed raised to 15 degrees. Prepare the equipments like measuring tape, an art stethoscope, our own stethoscope, Doppler, ultrasound gel, and so on. And a female chaperone should be there with us. Just a brief, a small video if it plays.
You wanted to the audio, madam? The audio is not there.
Dr. Meena, you're not audible actually.
You can
Just
say,
a
madam.
second, just a second. Okay, I don't know. It's audible to me here, this side.
No, it's
The
not audible.
technical team, anyone can do the thing. Is the voice is not there?
Hello, Meena ma'am. When you
Yeah.
share, there will be option of audio connect. You have to on that audio so other participant can see the. You have to
You
share again.
connect.
You can share it again, madam, after
Yes,
stopping.
ma'am. And when you share, I am stopping your screen sharing for now. You click on share button again. And there will be option in the right side, share sound. Click on that
Share
and then
sound.
share
I
your,
do not.
yes.
I'm getting the option of share.
Click on the share screen.
Yeah.
Click
Now
on
my presentation.
and I think there were three dots there.
Ma'am, when you click on share button, you will
Yeah.
see a tab of your share screen.
So I
Let
think
me
better
just
you
stop and
share it. I think
Okay,
better you
ma'am.
share it from.
Okay, ma'am. I will share.
Okay, please change.
आपका नाम पूजा चौहान है। ठीक है, हम अभी आपके पेट का जांच करेंगे ये देखने के लिए कि बच्चा सही से ग्रो कर रहा है कि नहीं, बच्चों का क्या पोजीशन है, बच्चा अंदर हेल्दी है ठीक है। उसके लिए हम आपको लगाएंगे पहले और केवल यहाँ से आके पेट एक्सपोज करेंगे। आप पेशाब करके आएंगे। जांच के दौरान अगर बीच में कोई भी आपको तकलीफ हो तो आपको तुरंत बताना है, ठीक है। चाहिए सिस्टर पर्दा लगाना चाहिए।
Okay, next.
आपका नाम पूजा चौहान है।
Next.
ठीक है, हम अभी आपके पेट का जांच करेंगे।
Ramna ji, please change the next one. Okay. So those were the preliminary things that we have to take care. Now the patient is lying with us. So what we have to do? We have to look at the shape of the contour of the abdomen, because this may give us an initial indication of the fetal line. Sometimes it is better done from the foot end of the baby, but yeah, anywhere below, from down below to up gives a good idea. Fetal movements may be visible to us, especially after 24 weeks of gestation. We should take a note of any surgical scars that are present because of any previous surgeries, be it laparoscopy or laparotomy. The physiological signs of linea nigra, stria, or strial gravidarum and all should be noted. Any scratch marks, so on and so forth. Next slide. Next. So here are two. In the first top one, we can see a previous scar, and in the down one, we can see the stria and the linea nigra. There is some suprapubic flattening also here. Next slide. Now coming to the abdominal palpation. Ensure that the patient is positioned properly and that her hands are warm and clean. We have to palpate the abdomen using even movements of the flat of the palmar surface of our closed fingers. Not prod with our fingers, but use the palmar surface, because jerky movements, they are likely to irritate the uterus and stimulate contraction. But more importantly than that, the patient may feel very uncomfortable. Next slide. So when we start the palpation, we have to tell the patient, we have to look at a facial and verbal response throughout. If there is any tenderness, note for any guarding. And the first thing that we do is take a fundal height. If the uterus is oblique, we would like to centralize it. Use the medial aspect of the left hand, because we are standing on the right side of the mother. Left is nearest to the patient. Starting from xiphisternum, working down to locate the fundus. Measure from here to the pubic symphysis in centimeters. It is a good idea not to see the centimeter marking so that we are not biased. After 20 weeks of gestation, the symphysiofundal height should correlate with the gestational age of the fetus in weeks plus minus 2 centimeters. Next slide. So this is what it is, looking for the border of the uterus. Next slide. So not only measuring in centimeters, but also noting where it lies in reference to the pubic symphysis, the xiphisternum, and the umbilicus. A uterus would be palpable at 12 weeks. It would be reaching just next to the xiphisternum at 36 weeks. It would be somewhere between the umbilicus and the pubic symphysis, 16 weeks. Just below the umbilicus, 18, just above would be 24 weeks. And the upper part, we would divide into 3 quadrants. The first would be 28 weeks, then 32 weeks, and then 36 weeks. We know that at 40 weeks, the head comes down. There is a descent of the fundal height with, there will be, the flanks would be fuller. Next slide. So very important, the Leopold's maneuver, that is the 4 obstetric grips. First would be the fundal grip, then the lateral grips, the first and the second pelvic grips. Next slide. Next slide. The first Leopold maneuver or the fundal grip. Actually, there are so many names. We have the Paulick and all that. But more important is to know what we are doing, the systematic way of doing it, then trying to remember all the names. So facing the patient's head, place the hands on either side of the top of the uterus and gently apply pressure. Palpate the whole fundal area. You have to be gentle. A soft, broad, irregular, not velatable structure would indicate a breach, while around it, smooth, mobile, hard, is a head. If we do not feel any pole here, it most likely is a transverse. Next slide. Now, what is a lie? Fetal lie refers to the relationship between the long axis of the fetus with respect to the long axis of the mother. And there are 3 types of lie. Longitudinal, when the head and the buttocks are palpable at each end of the uterus. Oblique lie would be when the head and buttocks are palpable in one of the iliac foci. And a transverse lie, the fetus is lying directly across the uterus. Next slide. Change, please. Now coming to the second Leopold's maneuver. Again, standing on the right side, facing the mother. Move the hands now from the fundus downwards. So we are trying to feel on the lateral aspect of the uterus. One side will feel fuller and firmer. This is the back. And the opposite side, we may be able to feel, the feet of the baby, the knobby structures. And while we are feeling one side, the other hand has to stabilize the uterus. Next slide. So when the back is felt on either side of the midline, it would indicate occipito-anterior. So while we are finding out there are things running in our mind because of the position of the back we are getting. If the fetal back is in the flank, then it is most likely occipito-posterior position. And if the head is felt in one of the flanks, it is a transverse. One may also be able to appreciate the tonicity of the uterus, the size of the fetus, whether it is the uterus feels full of the fetus or even, of course, corresponding to the size of the uterus or not. We may be able to appreciate polyhydramnios and oligohydramnios. Palpate and ballot the fluid to determine if there is oligo or polyhydramnios. When assessing the lie, only feeling fetal parts on deep palpation may suggest a large amount of fluid. Next slide. Change, please. Now the third Leopold's maneuver, or the first pelvic grip, again facing the mother, palpate the lower uterus below the umbilicus to find the presenting part. Outstretched palm is placed above the pubic symphysis. 4 fingers on the left and thumb on the right side. Firm, rounded structure signifies cephalic. Ballot the head by pushing it gently from side to side. A soft, non-ballotable round structure may suggest breech. And if the lower pole is empty, a transverse lie may be suspected. Fetal presentation refers to the anatomical part of the fetus which is closest to the pelvic inlet, which could be a cephalic presentation, a breech, or a shoulder in the transverse. Next slide. So the first one shows the lateral grip where one hand is stabilizing, the other hand is trying to feel for the structures. And the first pelvic grip with the right hand, we're trying to feel and ballot the structure down. Next slide. Now, the fourth pelvic grip, the second pelvic grip or the Leopold's maneuver, face towards, here we have to turn face towards the feet of the patient. The 4 fingers of both hands are placed on the either side of the presenting part and the fingers push down to reach the lower pole. So this maneuver is mostly important when the head is fixed or during labor, early part or the late part of the pregnancy. Here we are trying to confirm the presenting part, look at the engagement and the attitude. We've talked about the presenting part. Next slide. Next slide. Now, engagement. Fetal engagement refers to whether the presenting part has entered the bony pelvis. In late pregnancy, the level of fetal engagement should be assessed. If the entire head is palpable, the fetus is unengaged. A fetus is engaged when the BPD, the head is engaged when the BPD, which is the widest part, enters the pelvic rim. The fetal head actually is divided into fifths when assessing the engagement. If the entire head is in the abdomen, it is 5/5 palpable. It is not engaged. It is rather free. It may be floating as well. If not able to feel the head at all abdominally, it is 0/5, fully engaged. It may be 1/5, again it is engaged. So engagement may be measured in fifths. Next slide. And as far as the second pelvic grip is concerned, okay, here we will discuss it. This is showing the anteriorly, it's the sinciput, which is the most prominent part in the front of the head, and occiput in the back side, the most prominent part. So next slide. So in the second pelvic grip, when we are putting our hands inside, if the hands are converging below the presenting part is not engaged. Now it may be fixed till we may be able to converge, but if it has gone, the widest part has gone inside the pelvis, our hands will tend to diverge. That is how we look at it. Now coming to the fetal attitude. Now fetal attitude describes the position of the parts of the fetus body. A normal fetal attitude is commonly called the fetal position. That is a position of flexion. The head is tucked below the chest and the arms and legs are drawn towards the center of the chest. The lateral grips and the pelvic grips, they are needed to determine the attitude. They can help us in guiding to determine this. It may be flexed, it may be deflexed or extended. Next slide. Next. So in this picture, the first one, we can see it's a fixed attitude. The sinciput is higher and more prominent than the occiput, which is lower down. The second is deflex, also called the military position, where both the sinciput and occiput lie in the same level. The third picture, it is showing extension, and also which is in the brow position, where the sinciput is down, occiput is up, higher up. And the fourth position, it is a position of full extension or complete extension. Here, if one is careful, one can feel on the side of the back where we have, identified our back, we can even feel the sulcus. So this is what is the face where we may find the face presentation. Next slide. If it is a patient with a previous scar, we should look for scar tenderness. Here, if the patient's legs are a little flexed, that would help because it releases the pressure here. We could, even if it's a vertical scar, we know we're looking at the uterine scar tenderness. So down below, just above the pubic symphysis, we are trying to give a little pressure. It could be also with the kind of fourth pelvic grip where we putting a little pressure at the site of the uterine scar, which would be just at the level of the pubic symphysis. Keeping the patient, busy in talk, because if we ask, yahan dard ho raha hai, she will probably, in anticipation, make faces and say yes. But if she is busy talking, the involuntary wincing is what we are looking at. Next slide. So if it is a multiple pregnancy, we can, if it is a single pregnancy, singleton, we have 1 or 2 poles palpable. If 3 or more poles are palpable, we know it could be a multiple pregnancy. And also the uterus feels full of, fetus and multiple limbs and parts on palpation. Next slide. Next. Change, please. Now comes the auscultation once we've done with our palpation. Next, please, previous one, yes. Wapas jaiye, pichle baar, yeah. So we could have, okay, next, Pinard, stethoscope or electronic device. We can use any of these. Next slide. Next, change, please. So where we have located our back, we should put our instrument between the fetal scapulate, aim towards the heart. And we should feel the mother's pulse at the same time so that not to confuse maternal heart rate with the fetal heart. We should listen for 1 full minute, especially when she's in labor, and should be between 110 to 160 beyond 24 weeks. Next slide. Change, please. So location of the fetal heart sounds also give us some indications. Occipito-anterior position of the baby will we will be able to hear the fetal heart at the middle of spino-umbilical line. In occipito-posterior, it is way back in the flank, difficult to locate. In a flex breech, we can find it above the spino-umbilical line. And if it's a frank breech, it will be below the umbilicus in the midline. And transverse, it may even be above the umbilicus. Next slide. Change, please. So once we going to close the examination. Patient is covered. Step down from the couch. We thank her and explain her the findings and document our findings as well. Next slide. So this is a video.
Good morning. I am demonstrating the per-abdominal examination of an antenatal patient. For examination, I have already taken the verbal consent of the patient and she is lying down in supine position after voiding urine with head end elevated up to the 15 degrees. For examination, first we will expose the patient with maintaining her privacy. For exposing, on upper end we will expose her up to the xiphi sternum and on lower end we will expose her up to the pubic symphysis. Now we will start the inspection. In inspection, first we will see the contour of the abdomen. Here it is longitudinally ovoid, which gives us an idea of lie of the fetus. As in case of if the lie, it's longitudinal lie, but as if the case is of a transverse lie, the ovoid will change and the abdomen will look like a transversely ovoid. Next, we'll go for any visible scar marks or physiological findings of the pregnancy on abdomen. There is no previous visible scar mark, but the physiological finding of linea nigra is present along with stria albicans and ubra. Completing our inspection, next we'll move to the palpation. For palpation, first we'll start with the height of the fundus. For fundal height, we'll start our palpation with the xiphi sternum. With xiphi sternum, we'll look for the point of first resistance. At our point of first resistance, we'll measure the height of fundus with help of an inchy tape with the side of inches on the above so as to prevent the bias. We'll keep the upper end of the inchy tape on the point of first resistance and then we'll extend it up to the pubic symphysis. And later on, we'll note the findings in the centimeters. Then we'll start with the obstetric grips. For obstetric grips, first which is known as fundal grip, we'll place the flat surface of both our palms completely onto the fundus and to feel which part of the fetus is occupying the fundus of the uterus. In this case, the part which is occupying the fundus is a soft, globular, broad mass, suggestive of breach lying in the fundal area. For next grip, this is second Leopold grip, we'll slightly shift our hands to the lateral side of the abdomen. Palpating on the right, we'll stabilize the hand, feeling a smooth curved part which is suggestive of back of the fetus. And similarly on other side, I am feeling an irregular surface with knob-like structures which implies that the fetal limbs are occupying this part. For third grip, we'll shift to the lower side and outstretch our hands, thumb on one side and four fingers on the other side, and we'll keep it on the upper border of pubic symphysis and we'll try to grasp the fetal pole or the fetal head. Here, the fetal head is easily able to grasp the fetal head and it is easily ballotable from side to side, which implies that the fetal head has not engaged yet. For fourth grip, we'll face towards the feet of the patient and we'll keep our fingers of both the hands parallel to the inguinal ligament and we'll try to push them downwards and backwards direction. As my fingers are able to converge and meeting in medial side, it means the engagement of fetal head has not occurred. If the engagement has already occurred, then the fingers will diverge on their own. Next, what else we can see regarding the fundal height? Fundal height is usually, uterine fundus is just palpable at about 12 weeks of gestation. Between 12 weeks to 16 to 18 weeks, it is palpable midway between the pubic symphysis and umbilicus. At around 20 weeks, it is palpable along the lower border of umbilicus. At around 24 weeks, it is present along the upper border of umbilicus. After upper border of umbilicus till pubic symphysis, we'll divide it into three equal parts. The first part will correspond to around 28 weeks of gestation. Second part will correspond to around 32 to 34 weeks of gestation. And the last one near to xiphi sternum will correspond to 36 weeks of gestation. As the patient will move from 36 weeks to near the term, the uterine height will decrease, which is due to the engagement of fetal head into the pelvis, and it will descend down along with the presence of fullness in the flanks, and it will come around 34 weeks of gestation. This is regarding the height of the fundus. Now we'll go for auscultation process. Auscultation, we want to hear the fetal heart sound. For fetal heart sound, as I had already told that this part of the uterus is occupying the fetal bag. I can use three things, either hand Doppler, fetoscope or a stethoscope. Here I am using my stethoscope to auscultate the fetal heart. We'll auscultate the fetal heart for 1 complete minute and we'll try to evaluate either it is regular or rhythmic or not. Here the fetal heart is regular and has a rhythmic pattern. So we are completed with the inspection, palpation and auscultation of the abdominal examination. After doing the examination, what extra things can we see in the abdominal examination is amount of liquor, which gives us an idea of polyhydramnios or oligohydramnios. If the period of gestation is, if the fundal height is more than the period of gestation, and the fetus is easily velodible, it gives us an idea. It gives us an idea of polyhydramnios or more, that is liquor more than adequate. Similarly, if the abdomen is feeling like full of fetus and the fundal height is less than the period of gestation, it gives us an idea about the oligohydramnios. Then in last, after doing our examination, we'll sanitize our hands again and we'll cover the patient and we'll thank her for her time.
So then, of course, documentation is important, and we're
Good
going
morning.
whatever.
I'm demonstrating the per-abdominal examination.
So we're going to document all our examination in the patient's notes. Next slide. So thank you all and a happy Mother's Day. Thank you.
Thank you, Meena. Excellent demonstration come lecture. Very comprehensive and very effective for the students, I must say. Can I have a few observations and comments on your presentation?
Yeah.
See, so far as inspection is concerned, we always traditionally teach the students to go to the foot end or head end of the patient. Okay. If the head end is occupied in the examination, then please go to the foot end of the patient. That is one thing. Second thing is for palpation of the abdomen, we always ask them to follow 5 important prerequisites. They must follow before going into palpation. And they should know it from, in theory and in practice also. The first one is that after evacuation of the bladder, the patient is lying down dorsal on bed with the legs drawn up. Secondly, the doctor stands on the right side of the woman. Thirdly, rub your hands, and while you rub your hands, you take consent of the woman and explain to her. Fourth is exposure from xiphisternum to symphysis pubis. And fifth is presence of a chaperone. So I think you have done everything, but just for the remembering sake of the students during examination, we can jolly well do that these 5 steps before proceeding into palpation. Otherwise, don't do the palpation because the examiner will catch you. Okay. But anyway, it's a very excellent presentation, very, very useful for the examination. And just a last passing comment about the engagement, expression of engagement. When we express in fifth, we always describe that part which has gone in. That means either 0/5 in or 1/5 in or 2/5 in. We never describe what is out. That means 2/5 out or 3/5 out. So in means that part of it gives an idea about how much of the head has gone inside the pelvis. So I think, but it's a really good presentation. We thank you on behalf of ICOG, Meena. It was an excellent demonstration, come lecture, very, very useful for the students. Thank you very much. Thank you. Hafizur, the last part is the most interesting part of the ICOG session. That is the quiz. Please call the participants and the conductor of the quiz.
Yes. So thank you, Meena madam, for your excellent demonstration, as Ashish sir said. I hope it will be very much helpful for the students, at least for recapitulating as well as revising. So the last part, actually, Ashish sir, we are seeing the gradual and growing interest of the students because that's I have been seeing. Students are initially, they were a little bit of hesitant participating, but more and more number of students are interested. That's what we get from the queries. So I have already circulated the instruction to join there. And for conducting the quiz, we have from the quiz committee, Dr. Archana Kumari, she is chairperson, FOGSI quiz committee. Then we have Dr. Rajesh Ravi. Dr. Rajesh Ravi is Southern coordinator of the FOGSI quiz committee. And Dr. Priya Kannapan, she is state coordinator of quiz committee, Tamil Nadu. So I heard Dr. Archana madam is not there, but Dr. Rajesh and Dr. Priya Kannapan. Dr. Priya,
Yes.
is that true? Welcome, Dr. Priya and Dr. Rajesh.
Yes, because
Yeah.
Dr. Archana madam told she may not be able to join this time.
Yeah. So Dr. Rajesh and Dr. Priya, both of you can go ahead as far as you.
Actually, there is a question in the chat box, so you want to finish that?
Ashish sir, can you see the question?
Whether to flex the leg for all the maneuvers.
Yes. I think that except inspection need to keep the legs straight. But for all the maneuvers, I think flexing the legs is important because it relaxes the woman. It is not that it relaxes the abdominal muscles, but it relaxes the woman. That's very important. Any other
thing for symphysis fundal height measurement also, I think we will not flex the leg.
Correct. That is, yeah, you can keep it straight, and measuring the symphysis fundal height may need a straightening of the legs also. That's right.
Yeah, Dr. Rajesh and Dr. Priya, you can go ahead, proceed with.
Thank you, Dr. Hafiz sir. Respected ICOG team. Ashish sir, thank you for this opportunity from the quiz committee and all the other office bearers. So now everybody is familiar with the Kahoot quiz, so I will share the screen for the game pin as well as the QR code, and those who are familiar can go on with it, and those who are not familiar, you can go to www.kahoot.it website. If you have an app, you can also go to the app and you can enter the game pin. Are the delegates in a separate link, Dr. Hafiz sir?
Yeah, they are in a different, but I'm sure they are able to join because that was the way it was conducted in the last few sessions. So
Okay.
I think you can proceed for joining to them. How much they are? How do you know how much they are joining?
It's coming on the screen. It's coming on the
Yeah,
screen.
it's coming.
Yeah.
Yeah. So all the students, you can, as per instructions, you can go ahead with the joining. So you'll have a few minutes for them to join.
Yeah, sure.
As far as possible, I'd request all the students to write your at least the first name, complete name, so that it becomes easy for the quiz masters to take your name as well as while declaring the awards. Those are winners, the first three.
And only the top 5 will be on the screen, so don't feel bad if you are not scoring good marks. Nobody will see. Only the top 5 will be there on the screen. So I would like to congratulate the today's program, because it was one of the programs where we went to the base I was listening on and off to the case discussion as well as the class on the obstetric examination. Then only we understood how much of the basics we have been forgetting many a times. So congratulations for bringing up this topic, and actually was the need of the hour for all the postcards also. Everybody are discussing big things, but somewhere the revisiting the basics is also needed. So we have as of now
38.
38 participants.
Wait for a minute or so because we can still see
Yeah.
people joining.
The students are
Yes.
joining. This was, I can remember initial, I think the very first program, only a few of the students joined. But as the program is going on, there is growing interest because they are also understanding and the curiosity is also increasing.
So the topic for the quiz will be pelvic organ prolapse, and since it's a topic of, today was more about basics, we have 4 or 5 questions for basics. Maybe something related to obstetrics also, but still we'll be doing some 4 or 5 questions on the basic anatomy also, and some few questions, not much questions. We have some 25, 20 up to 30 questions maximum. So it will be over in another 15 minutes time, maximum 20 minutes. So we are 48 now. We'll wait another 1 minute and we'll start.
Yes.
Okay, I think we'll slowly start. We'll keep the program unlocked because if anybody wants to join in between, they can also join. So if those who are not done Kahoot quiz, just see that the questions will be demonstrated on the screen as well as your mobile phone, and you will have to select the correct option which is being demonstrated either on the screen or the phone. So you have to look at the correct option and click on the option. And mind you, all the questions are fastest finger first. So those who answer early will be getting more marks compared to those who answer late. So even though you get same correct answer for 2 persons, but the person who has answered first will get more marks. So with that introduction, I will start. Dr. Priya Kannappan will be joining as the quiz master, and Madam is coordinator of the Tamil Nadu State Quiz Committee. So welcome, Madam.
Dr. Regis, there is no negative scoring, right? So you can
Yeah, no
emphasize
negative.
them. So the students, everyone can attempt at this.
Yeah. No negative.
Only thing is the speed matters, sir. Like, if you just make microseconds, so then even if you go wrong by 1 or 2 questions, you can still be the topper there. So your speed matters more also.
Okay, please go ahead.
57, should we start? I think we'll start.
I think you can start.
Yeah, seeing no more. Yes. So welcome and happy Mother's Day, everyone. So in this celebration, so few questions on the pelvis. It's very simple. You can even think it of, okay, these are questions. So similarly, like it's very simple questions. So are we having the first? Yeah. The question number 1. What is the difference between a female and the male pelvis? The differences are all except the large and broader, tall and narrower, wider subpubic angle, wider sacrum. The difference between a female and male pelvis are all except. Yes, most of you have got it correct because the male pelvis is tall and narrower. Yes, next question. So it is Sahira who's standing first, but everybody like, okay, the other 5, you can like, still come up to the top one. Yep. Next, please. Which pelvis favors occipito-posterior position? So in the diagram is the picture A, B, C, or D? Okay, yes, it is the answer is A, which is the anthropoid pelvis. So it is Paritosh who's come first, followed by Dr. Haram and Supriya. Very good. Good job, guys. So name this pelvis which is in the image. So what is this kind of pelvis? Whether it's an android, anthropoid, gynecoid, or the platypuloid? Paused or something? The seconds are not moving. Yeah. Okay, but most of you have like, this time missed that. And Dr. N has climbed to the top place. Yes, it was a transversely widened pelvis at the level of pelvic inlet, which means it's a flat pelvis, a platypuloid pelvis. Next, please. Which of the following, like in which situation there will not be a vaginal delivery? Is it the A or the B scenario or the C scenario, or all 3 of them can deliver vaginally? Okay. So once most of you are there, we can just give you what is it about. So this is, yes, it's a phase presentation and your mento-posterior will not deliver vaginally. So you just have to see the other 2 were left mento-anterior and the right mento-anterior. Next, please. So it was Dr. Haram who's first, followed by Madhulika and Geetanjali. Good job, guys. Next, please. Not an important of ischial spine. So there are a lot of features which we say ischial spine's importance. Attachment of the sacrospinous ligament, landmark for the obturator nerve, landmark for the pudendal nerve, and it's an anchor for the endopelvic fascia. So usually people have this favorite question, one of the favorite question in your clinical examination, when they ask what is the ischial spine's importance in both obs and gynec. Most of you have got it correct. Yes, ischial spines is not for obturator, but it is only for pudendal nerve. Next, please. So it is Dr. Madhulika who's scoring first, followed by Dr. Tripti Nath and Geetanjali. Very good. Next, we'll go. So now we have the questions about the pelvic organ prolapse. So levator NA injury results in which of the following? Does it cause an anterior compartment prolapse, a posterior compartment prolapse, a apical prolapse, or all the above? Yes, actually, most commonly it causes the apical prolapse. Yes, it also makes major part in anterior compartment and some role in posterior compartment as well. So all the above is the right answer. Next, please. So the scoreboard is pretty much the same. So Madhulika is taking the lead and MSD is climb up. So in POPQ, the point C represents the most distal part in the anterior vaginal wall, the vaginal vault, the most prominent part of the posterior vaginal wall, or the cystocele. What does the point C represent? Okay, there is some distribution. Yes, your, usually point C represents the cervix or the vault. Next, please. So scoreboard is the same with Dr. Madhulika there, and Dr. Janvi is the highest climber. So well done, and MSD and SJ have also come to the scoreboard. Good, guys. Next. Which type of prolapse is best diagnosed with a dynamic MRI? So is it the uterine part of the prolapse or the bladder or the urethral prolapse, rectocele or the enterocele? Oh, I thought everybody will pick it up. No, the other three you can pick it up with clinical examination. Only enterocele is difficult. So that's why you use a MRI for that. So that's the main thing which you wanted. Next, please. So MST is climbed up in the first position. Congratulations with Dr. Madhulika and Tripati Nath. Next, please. D-Lancet support for pelvic organ prolapse, pelvic organ describes cystocele stages, uterine ligament support, vaginal support mechanisms, the enterocele. So there'll be a pretty diagram in every gynec textbook. I hope you have all seen those things. 3 levels of support. Oh, okay. I thought I give you that so that you'll get confused and you took my bait there. So it is not the uterine ligaments. Your D-Lancet is more with vaginal support. So level 1, 2, and 3. Your topmost level alone is uterine ligaments. The other two are not the uterine ligaments. Next, please. So congratulations, Dr. Tripti Nath. You have climbed up there, followed by Dr. MSD and Shruti. So good job, guys. So strongest predictor for successful pessary fitting test. So is a longer total vaginal length, a shorter perineal body, a larger genital hiatus, the age of the patient. So when you do a pessary fitting test, so which will be successful? So for which patient the pessary will be helpful? So in these conditions. Okay, that's taller, stronger, total vaginal length is correct answer because you need to have a larger perineal body, a smaller genital hiatus, and the age does not matter for the pessary fitting. Next, please. So scoreboard, yes, congratulations MSD for climbing up, followed by Dr. Madhulita and Dr. Shruti. Very good, guys. So identify the false statement regarding a vaginal hysterectomy. It can be done in uterus of size 12 to 14 weeks, can be done in the uterus with associated fibroids, at least a risk for urethral injury as compared to a TLH, can be done in frozen pelvis. Very good. Most of you have got it correct. Congratulations. So scoreboard is pretty much the same. Congratulations for Dr. MSD still staying on the top. Yes. Next, please. The most common serious risk for vaginal surgery for prolapse is hemorrhage, bladder injury, vault prolapse, vault hematoma. Usually, any of these risks are less common in vaginal surgeries. We all know that. Of these, which is the common? Oh, no, you hardly see bladder injuries. Your technique matters, but usually we don't do that. And hemorrhage is point to be, though it is 1 in 1,000, that is the commonest, severe risk in vaginal surgeries. Next, please. So scoreboard is same with Dr. MSD in the top. Dr. Samiksha, congratulations to climbing up. Very nice. Next. The lowest recurrence after surgery for wall prolapse is with the vaginal sacrospinous fixation, the abdominal sacrocolpopexy, uterosacral ligament suspension, or the Leafold colpoclysis, which has the lowest recurrence. Very good. Most of you have got it correct. Yes, there is confusion about Leafold, but still compared to Leafold, abdominal sacropexy is a better surgery with much better, less recurrence rate. So scoreboard is same, and congratulations to Dr. Aditi for climbing up and entering into the top 5, and MST, congratulations. Next, please. The major complication of sacrospinous fixation is chronic constipation, buttock pain, hemorrhage, injury to the bladder. So that should be a ECBC questions for you. Okay, most of you have got it because the nerve which is there is your pudendal nerve injury, which is following your buttock pain there. Yes, congratulations, Dr. MSD, followed by Dr. Madhulika and Swatika. Next, please. The risk of de novo stress incontinence after a prolapse repair is minimized by preoperative urodynamic testing, mid-urethral sling surgery at the time of prolapse repair, postoperative pelvic floor exercises, prolonged catheterization, which minimizes the stress urinary incontinence after a prolapse surgery. Okay. I mean, urodynamic testing, yes, but testing alone will not minimize. Repairing the condition minimizes your risk. So, okay. So, Dr. MST, congratulations for staying on top, followed by Dr. Swatika and Samishka. And NK is climbed up with the maximum streak rate. So, congratulations, guys. So the surgical repair where the pubocervical fascia is plicated in the midline and laterally it is attached to the arcuate fascia, tendinous fascia is colpoclysis, uterine prolapse surgery, cystocele. I'm sorry, we just missed this one, right? No, it is done for which of these? Okay, is it done for as a colpoclysis procedure, or is it done for any normal uterine prolapse, or is it for rectocele? Yes, you got it correct. Thank you. So yes, it is an anterior repair. So anterior repair is done for cystocele. Yes, congratulations. So the scoreboard is pretty much same and Shruti has made a climb up there. So Dr. MSD, Swatika, Shruti, congratulations. So a 76-year-old para-4 live, he has urgency, frequency, as well as nocturia, mild cystocele with the post-void residual urine of 400 ml. The diagnosis is urge incontinence, overflow incontinence, urinary tract infection, or a functional incontinence. Oh, I thought you'd pick it up very easily. It is a kind of urge, but it is not like, just urge. It is a overflow because your post-void residual urine is high. So it is a detrusor inactivity. So we wanted a little more of detail into that. So I think my sessions are over. So congratulations for Dr. MSD to stay there. And Dr. Shwatika, Shruti, congratulations. And Ankita is the maximum person to climb the streak. Good job, guys. So I will hand to Dr.
Yeah,
Rijal.
thank you. Thank you, Priya Madam.
Thank you.
So we'll move on with the questions. So few more questions left. And as of now, it was actually pretty good fight at the top. The names are going on changing. So another 10 questions, we'll see where it will, who will be the winner. So the next question. So 49-year-old woman who had multiple fibroids is booked for TH. So what is the risk of developing a wall prolapse? After TH, what's the risk of developing a wall prolapse? Whether it is less than 5%, 6 to 12%, 15 to 20%, 26 to 30%. So this is one of the things that we are afraid of after hysterectomy. The same patient comes to us after some time with prolapse. So the risk is almost 5 to 10% or 6 to 12% as shown in textbooks. So that much high is the risk of wall collapse. If not properly done, the risk may go again. So again, we have changes in the top 5. And going to the next question. So you know about the classifications of genital prolapse. So which of these is not a classification of genital prolapse? Beden-Wacker classification, Malpass classification, POPQ, Scher's grading, Beecham classification, which is not a classification for the genital prolapse. For the postgraduates, and so the questions usually there is one question going right about all the classifications of genital prolapse. So you may be.
For me, it was like, describe every classification.
Yeah. So which is not a classification. So Scher's grading doesn't come under genital prolapse. All others, Beidenbecker and POPQ are the commonly used one, but lesser known ones are the Malpass and Beecham classification. So many has got it correct. So very good. So the scoreboard goes the same. Next question. In 85-year-old with coexisting medical conditions come with stage 3 prolapse, which is the preferred management? Whether it is Manchester surgery, Fothergill surgery, sacrocolpopexy, or Leaford surgery. So the basic UG question, but still good to know that everybody knows that. Yeah, many has got it correct, but I am not sure why some people has got it wrong. This 85-year-old patient with coexisting medical conditions always does not go for any major surgeries. So we usually prefer bedridden patients or patients who are not fit for surgery. Leaford surgery is the preferred management. Manchester surgery or Fothergill surgery is usually done for nulliparous prolapse or in patients who are in the reproductive age who want to retain their uterus. So now the scoreboard is almost similar, not much changes. So drug of choice for detrusor overactivity. So detrusor overactivity happens, which is the drug which you prefer to use: amitriptyline, duloxetine, mirabegron, and oxybutynin, which is the drug of choice for detrusor overactivity. So that is oxybutynin. Many has got it wrong. Okay. So Nikita,
wrong, but that's not the first line. So I think they have
drug of choice is the question. So Nikita has climbed up to the 3rd place. Otherwise, it's normal. So which point in POPQ is omitted after hysterectomy? So if the hysterectomy has happened, which is the point that is omitted? Whether it is total vaginal leg, whether it is point C, whether it is point D, whether it's point AP. So there is some change for wall prolapse in POPQ points. We have only 8 points. And if you have listened to the earlier question, there was actually one question similar to this when Priya Madam was conducting.
Yeah, the
so
clue
points,
was there.
Yeah, still 16 has got it wrong because point C will also correspond to cervix or the vault. So the question was that earlier, and D is the point where the uterosacrals are attached, and after hysterectomy, that point doesn't have any significance. So that is not present when there is a wall prolapse. So D is the correct answer. D is omitted. So Madhulika coming back to the top 5. So most commonly injured vessel during sacrospinous fixation is inferior gluteal artery, internal pudendal artery, uterine artery, vaginal artery. So sacrospinous fixation, many times we do when we do vaginally, we doesn't have much visualization, and we usually go with more by palpation, and which is the vessel which can be injured. So the most commonly injured one is the inferior gluteal artery. Okay, so many didn't got it correct. So
Okay,
inferior gluteal artery is the most. So Nikita climbing up. So for the sling surgeries, which of the following is a dynamic sling? Whether it's Shirodkar, Purandare, Ganna, or Joshi. There are dynamic slings. So which of the following sling surgery? As you know, the sling surgeries are can be done without removing the uterus. So the answer is Purandare, and most of you has got it correct. So Soya has entered to the top 5. So back to Manchester repair, which ligaments are primarily shortened in Manchester repair? Whether it is uterosacrals, whether it is cardinals, whether it is sacrospinous, whether it is round ligament. So Manchester surgery is otherwise known as Fothergill surgery. I already told it is done for patients who want to retain the uterus. And which are the ligaments? Okay. Oh, cardinal ligaments is the correct answer. Previously it was thought that the cardinal ligaments are the one which was the main ligaments. That's why the macron rods were known as cardinal. And what they do is they cut short the cardinal ligaments and fix it to the anterior part of the uterus. And one of the major things against Manchester surgery is that it is using the cardinal ligaments and not the uterosacral. So that is the one which was against the Manchester repair. So there is also cutting short of the cervix, stemmed off sutures, cardinal ligament shortening, and attachment. These are the components of the Manchester surgery. So the points almost similar. We have few more questions left. So which is not a preventive technique for wall prolapse. When you're doing a hysterectomy, which is not a preventive technique. Meckel's scaldoplasty, sacrospinous fixation, sacrohystropexy, suturing cardinal and uterosacral ligaments to the vaginal cuff. Which of the following is not a preventive technique? Yeah, that's the correct answer, because all the others, that is when you're doing hysterectomy, you can do a Meckel's scaldoplasty, you can do a fixation along with the vaginal hysterectomy. You can, even if you're doing an open surgery, you can go for suturing the cardinal and uterosacral ligaments to the cuff. And sacrohystropexy is a sling surgery, and the name itself is explanatory. Hystro means the uterus is still there. So it's not something for wall prolapse, it is just for a normal prolapse uterus. So again, changes Ankita, and many of you got into the 14,000. And I think it's the last question. And in Shirodkar sling procedure, which is attached to what? Cervix is attached to the sacrum. Cervix is attached to the anterosuppral iliac spine. Cervix is attached to the anterior abdominal wall. Cervix is amputated. So what is done in Shirodkar sling procedure? Yeah, most has got it correct. The cervix is attached to the sacrum. So that is Shirodkar sling surgery. And by that, we come to the end of this session, and we'll go to the podium. So the third prize with 15,000 points, Dr. Samiksha, congratulations. Nigida at second position, and first position is MSD, who has maintained the first prize of the second half of the quiz. So congratulations to all the winners. And I would like to thank the ICOG as well as Chairperson for FOGSI Quiz Committee, Dr. Archana Madam, for giving us this opportunity. Congratulations to the winners, and congratulations all to delegates who has been participating. And thank you, Priya Madam, for being with me. Thank you.
Dr. Rajesh, thank you, Archana Madam, for the opportunity. And thank you, ICOG team. Thank you, Dr. Ashish. And thank you for the coordinators today. Thank you, sir. Thank you.
Thank you, Priya and Rajesh. It was a wonderful conduction. It's not easy to conduct a quiz on prolapse uterus because, in the process of selection of questions, a lot of time goes. Anyhow, it was a good thing done. And the winners are all okay, second and third. Who is the first position? Who is MSD?
Yeah.
One dot.
I hope it is not a company.
Even I thought so. They can just put your name in the chat box with the hospital or with the medical school which you are studying, so that it will be very nice to know.
So for the winners, we need all of your details. So please you can post in the chat box so that whatever the winning award, ICOG can send to all of the top 3.
So I think all well that ends well. You have done wonderful quiz, conducted very well, extremely useful for the students. For prolapse, I will say it is a kind of a resurrection or a kind of, revision of the old topic. And you have done a perfect combination of what is recent advances and what is textbook teaching. So I'm very grateful. On behalf of FOGSI, we thank you, ICOG, we thank you very much for this quiz competition. Thank you so much. So Hafiz, we would like to close this year.
Yes, sir. I think we can conclude, sir.
Congratulations to the winning members, and also our teachers, Priya.
Yes, sir.
Thank you so much.
So, thank you so much, all the quiz masters, and including Dr. Archana. And overall, we would like to Thank you, the FOGSI President, Dr. Sunita Tandalatkar Madam, and the ICOG Chairperson, Dr. Parag Binwale Sir, and Vice Chairperson, Dr. Ashok Kumar Sir, along with all the other office bearers, Secretary, Dr. Sarita Bhalerao Madam, and along with me, Dr. Ashish Mukhopadhyay Sir, for always being there on second Sunday of the every month for conducting this program. I'd like to sincerely thank Arup Mazhi Sir for taking the important class. Then along with the AIMS Raebareli students, Dr. Jaya and Dr. Aditi, and their guide, Dr. Vandana Verma, for having your students on this Sunday for this program, with all the faculties, including Ashish Sir, Dr. Nirmala, Dr. Manideep Paul Sir, Dr. Deepa Lupani Madam. And then we have another session for these methods of obstetrical examination by Dr. Meena Samant Madam. So I'd like to sincerely thank all of you, including the quiz committees, the quiz program recently conducted. So thank you so much. Any comments, or we can, Ashish Sir?
We have got the names of the students in the chat group. You can just read it out, sir, so that the HODs and others are proud of that.
Yeah, MSD. It is M. Sri Devi. Yeah, where are you from, Sri Devi?
Mookambika Institute of Medical Sciences.
Okay. So now it's clear, Ashish Sir is not medical company. She's a...
I'm happy that the prizes are not going to a company. Thank you so much.
Yeah, thank you so much. Ashish said the final words, or we can conclude.
Yeah. I think from the core of my heart, I must thank you, the quiz masters and all the participants. They have done wonderfully well. And this quiz has added a new flavor to our ICOG program.
That's true, sir.
And we are in the process of adding more and more, innovative ideas in the teaching session to make it interesting. I know it's a bit prolonged teaching. Maybe we'll think about the duration of the program or extent of the program. It's quite past lunchtime. But then I think an old man like me, if you can enjoy up to 2:30 p.m., then I think my younger representatives can easily can. Thank you so much.
Yeah, thank you so much. Have a good day. Bye-bye.
Thank you, sir. Thank you.
Host team, you can stop recording and thank you so much, all the host support team.
Thank you, sir. So from here, I'm ending this session. Thank you.
Thank you.